competence assessment. Suppose we have incubator ambulance transport. It was opened after 1 year because no one knows how to use it, and there was no demonstration or thing like that. And second is like half of our facility, I admit that they don't have even AED.
You don't have
AED, automatic
electric
defibrillator. So that's also an issue. And second one is 52% of the population doesn't have insurance.
Yeah.
That Ayushman data is from SCCC 2011. And
but even at the best, by its own admission, it was only 40% of population. So 60% will not be covered under Ayushman Bharat. Anyhow, even if we do a very good job, obviously it depends on the district wise. 40% is the national average. District could be slightly above or lower, but we'll always have people who are not covered by insurance unless we have some other mechanism.
That competence-based assessment mechanism, something should be there.
I agree. So ultimately, all emergency services to be one. You cannot have a separate cardiac emergency, separate maternal emergency. So ultimately, all emergency services has to be comprehensive to provide any emergency. No, we can't have separate ambulance for cardiac or for maternal. So this is a much bigger issue than just a cardiac condition.
So this is a little bit more on the calculation on the delays. So sir, don't you think that if the delay at the level 1 is there, that will automatically compound onto level 2 and 3?
In terms of time, yes.
So a calculation of this delay, should it be done standalone for level 1, 2, 3? Because when level 1 is delay is kind of documented, automatically level 3 will go down.
Yeah, in the sense that when we say level 3 delay, it means that the delay which has occurred after the patient has come. That's the definition of level 3. So it cannot be cumulative because the starting of level 3 is that after patients reaches the health facility, what is the delay? So it does not mean that there is no delay before it. There could be a delay before it. So we could analyze the same data, but how many had delay at level 1, 2, and 3, level 1 alone, level 2 alone. That time kind of analysis can be done.
And I guess increasing awareness among people and then not developing an infrastructure will pinpoint level 3 delays remarkably. So we need to fast track the preparedness of the facilities.
Yeah.
Because if we just look at causing awareness, then
exactly.
naturally
people
obviously
you are going to increase demand without being able to provide a supply.
So we will see a lot of level 3 then perhaps.
Yes.
So
they are, yeah.
So to decrease the delays, like one of the option you have mentioned is training local practitioners. Like
to do what?
To decrease the delays in the.
What will local practitioners do? We are saying, I said they should be able to recognize and refer. That we should do. Like, not manage.
Who comes under the local practitioners, sir? Like either quacks or MBBS doctors?
That's a much bigger debate. I think if you want to save patients' life, we should not get into this debate. Train everybody. What is the problem? We are only training. You can train even common people on how to recognize and go to write. So why not train even quacks? What is the problem? There is no problem.
Like I'm just curious to know, is there any data regarding number of local practitioners in India or any specific area?
Unfortunately, we don't have. There have been some surveys which have done, but national level survey has not been done. But yeah.
If you see AFT cases referred by the government practitioners or quacks, there are more.
So yeah, so many of those other services, like even in TB, we involve many of them. So we have a list of, maybe informally, but we have a list of local practitioners.
So is the training was it conducted or is it going to be conducted?
I don't know. Somebody has to fund that kind of training, isn't it? It's not a part of our funding to do that.
Thank you, sir.
Sir, my question is whether this Mission Delhi project is still functional or...
Yeah, it is still functional. Yeah. First phase is over. We are now moving to second phase. First phase was restricted to AIIMS. In the second phase, we are looking at 2-3 districts. One of them is Faridabad. I'm forgetting the other.
2-3 districts of Delhi or outside?
No, outside.
Okay. And sir, this Mission Delhi is basically capturing the area of South Delhi. And there is the...
Phase 1 was more of proof of concept. Yes, it covered only south of Delhi.
And we have the hospitals like big hospitals,
Agreed.
GTV, Loknayak,
Agreed.
where this Mission Delhi can also be replicated.
Well, sorry, I think second, this we are doing it with Wellington Hospital. The second place it is going to start is the RML Hospital in Delhi. That's the second place where we are. RML and I think Faridabad are the next two. In phase 2, we are doing that.
We have an online question on the screen. The patient who could not recognize the disease and could not reach any health institution and ultimately expired, how the cause of death was ascertained? Is it only by verbal autopsy?
Yeah, for everybody, the cause of death was by verbal autopsy. Even if they died in hospital, that would be captured in the verbal autopsy, that the cause of death told at the hospital was whatever ABCD. But the final cause of death for everybody has come from verbal autopsy. Okay, I think we can now go to next, which is on focusing on cardiac care and. Welcome, Ambuj is a professor of cardiology and we work closely with each other. He was part of the previous study also. So maybe if we want to.
Dr. Ambuj Roy is professor of cardiology and professor in charge of skill and telemedicine center at AIIMS New Delhi. Sir is fellow of American College of Cardiology and fellow of Royal College of Physicians. And sir is also member of technical expert committee for NPCDCS. Sir, you can start.
Good afternoon, everybody. Can you hear me? Yeah, okay. And I hope you can see my slides. So I think the stage has been set by the previous study presented by Dr. Anand, and it was, I mean, when we wrote this, we were kind of expecting this, but it has really put to perspective how much improvement CVD care, NCD care in general, and especially acute conditions like MI and stroke need. So my talk is on strengthening CVD care. It's not unusual for us to see these headlines day in, day out in the news, and especially more so when the heart attacks hit the so-called stars and people who are in the glamour world. But as you saw from the data, almost 1 in 5 of our heart attacks occur at very young age, under 45 years of age, and that's because of multiple reasons, and which I'll discuss with you, and what could be possibly done to improve that. So I'll just briefly discuss the burden of CVD, what CVD management strategies should be, what are the low-hanging fruits that we should address as preventive measures, because we know we are a low resource country, and we need to really focus on prevention as far as possible. I mean, everybody should focus on that, but especially us, and talk about some of the innovations that have been, there is proof of concept, and that could be scaled up to improve and strengthen CVD management. So, the numbers are mind-boggling. We have a hypertension population of over 200 million. So if we were just to put the hypertensives of India as a country, we would be probably the 6th largest or 7th largest country in the world, the population of hypertensives in India. Diabetes, another 65 to 77 million, according to different estimates, and similar numbers for people living with ischemic heart disease. And you can see from this global burden of disease risk factor burden why this is so. So all these risk factors for cardiovascular disease are the leading risk factors, whether it be dietary risk, high blood pressure, tobacco use, high cholesterol, high plasma glucose. So they're right there on the top 5-6 risk factors prevailing in Indians, and air pollution also, which we also now know is an important CVD risk. And this we saw between two surveys done again in the National Capital Region, one urban Delhi and other was Pallabgarh, where Dr. Anand was involved. And we clearly saw both in urban, and especially in rural population, the massive increase in the risk factors, whether it be obesity, whether it be hypertension, whether it be diabetes, between these two surveys done about 2 decades apart. So almost doubled, these risk factors doubled in urban and almost tripled in rural parts of India, because nothing is rural now, because of the exposures, because of the changes in lifestyle, because of changes in dietary habits. Increasingly, we becoming rural and urban differences are narrowing down. But what was most worrying, that between these two surveys, what we did not see an increase in, and which we would have liked to see, is the change in the patterns of management of hypertension. For example, the awareness, the treatment and control remained right the same between 2 decades. No improvement in the two, in either of these. Which and this was in National Capital Region of Delhi. So you can imagine other parts of India, what the condition might be. So this is what is available data from most parts of India. For example, if we talk about hypertension, just about 1 in 3 people are aware of their the prevalence is 1 in 3. Awareness is quite low. It's one in 3 people are aware. Again, treatment is again rural, urban. There's a difference, but again quite low, and control rates are pretty abysmal. In single digits in rural India, and in urban India, only 1 in 5 people have their blood pressure control. So the number of hypertensives living without their control, if we just do a back of envelope calculation, would be 165 million. And imagine the impact that would have on cardiovascular disease burden. So obviously there are things that need to be done. The way we are going about doing it is not right, and we need ways to improve on CVD risk management so that we can possibly reduce CVD burden. And the same for diabetes. So this is from the ICMR India study. And if you see, just about 1/3 of the population had their HbA1c less than 7. So 2/3 people did not have their diabetes under control, and 1/4 of them had a HbA1c of over 10. So we're not doing well over there too. Sorry. So, I mean, you're very much aware of these risk factors for ischemic heart disease or atherosclerotic cardiovascular disease. These are the major risk factors, whether it's the high blood pressure, diabetes, bad cholesterol, central obesity, tobacco, physical inactivity. So I'll just focus on 2 risk factors, and what the impact of managing that is. For example, for every 20/10 millimeter increase in blood pressure in a cohort study, in multiple cohort studies, and this is a review of multiple cohort studies, has shown that the risk of CVD mortality doubles. So for every 20/10, starting right at 115/75, and for every 20/10 increase in blood pressure, the mortality doubles. And by just reducing your systolic blood pressure at any level by 10 millimeters, or a diastolic blood pressure by 5 millimeters, you can reduce ischemic heart disease by 20%, stroke by 35%, heart failure by 40%, and you can reduce overall mortality by 13. So by reducing this amount of blood pressure, you can prevent 1 event of CHD, stroke, heart failure if you treat 40 people. So it's obviously one of the most cost-effective strategies, because blood pressure medicines, as you know, is pretty dirt cheap and easily accessible. And there is no reason why everybody should not have their beyond blood pressure control measures. So increasingly, we need to be, so this can be achieved only by increasing our opportunistic screening strategies. That is, every adult coming in contact with at a healthcare facility above certain age, of which could be 25, it could be 30, depending on resources, should be screened for adults for whatever condition they would be visiting or making contact with healthcare worker. In fact, there is this of screening in population too. Our target blood pressures should be 140, less than 140, 90. and possibly now in high-risk individuals less than 130/80. And single pill combinations are now preferred because we know at least 2 medicines are needed on an average needed to treat hypertension. So increasingly, pill combinations which have better compliance and have better control of blood pressure are recommended by guidelines. They're not available in our most of our healthcare setups, but I think there is need for this to be introduced so that we improve our blood pressure control rates. And hypertension, being so common, can be a gateway for screening and managing for other cardiovascular risk factors. Let's talk about diabetes. So, I mean, again, to this audience, I need not tell you that diabetes is a risk factor for cardiovascular events, and it increases chances of coronary artery disease, stroke, peripheral artery disease, heart failure, and or MACE. That is a combination of these by 2 to 3 times more in women if you're diabetic than if you're not diabetic. But what is important is and this seen from this registry by Roshani et al. It's a Swedish National Diabetes Registry. That all is not lost if you're diagnosed with diabetes, and if you not only manage your diabetes but other comorbidities, that is, have your blood pressure less than 140/90. If you have managed your renal effects, if you don't smoke, and if you manage to have all the diabetics cholesterol less than 100 milligram per deciliter, 97 in this case, then what do you see? The risk for future cardiovascular events become as much as for non-diabetics, right? So this one is a little important to understand. So these are the controls. These are that is age-matched people without diabetes. And if you have no risk factors, right? So if you see here, there is some increase in those less than 55 years, but not statistically significant. But practically for everybody, if you manage these risk factors and have a diabetic control for all those 5 things that I mentioned, then there is no excessive risk for future cardiovascular event. But what if you don't? And if all your risk factors are haywire, then you're in a less than 55-year-old, there is a 5-time higher chance of having a cardiovascular complication. And it becomes of excess MI is 8 times higher in young people and 4 times in elderly. So diabetes, the diagnosis is not such a big issue, but if you don't manage the comorbidities, then it's a problem. So obviously we need to do that better. Let me look at one more situation of CVD, which is acute STEMI management. I thought I'll discuss 2 chronic conditions and 1 acute condition in terms of CVD management. So what is your goal of acute heart attack management, which is ST elevation MI? That is, you have ST elevation on ECG. So it is a real emergency. It is a case for expedited management, and every minute counts. So as you know, acute heart attacks, as you can see in the cartoon here, occurs because there's a clot forming inside your artery, and there's a blockage of blood supply to certain parts of the heart, depending on which artery gets knocked off, and that area starts necrosing, right? And you need to restore blood flow to salvage myocardium and improve outcomes. So let me ask you this question. I don't know whether we can interact on this, but which of the following do you think would lead to maximum benefit in reducing mortality in a patient of ST elevation MI or an acute heart attack? Aspirin, clopidogrel, heparins, streptokinase, which is a thrombolytic, or reducing the time of revascularization from 6 hours to 1 hour. I wish I was there and we could do a hand count.
We can have them raise their hands and quickly say who believes in one. One, there is only one person who says 1.
Okay.
2. Clopidogrel.
These are all proven.
Number 3.
Yeah.
Not
I think
many.
the
STK
thrombolytic.
and the fifth one. I think majority, I think fifth got the maximum vote.
Yes, I think the question is framed like that, but yeah. So these are all proven things of proven benefit. So you'll be surprised that just an aspirin tablet can reduce the mortality by as much as a thrombolytic can. And this was in the large ISIS trial, one of the very early trials of thrombolytic, where they had a 2x2 design. They gave aspirin versus streptokinase, and the level of benefit by both was similar individually, and of course the combined benefit was more. So whenever you are suspecting an heart attack, just give the patient an aspirin tablet of 325 milligrams to chew. That's the best first aid you can give. You could add a second antiplatelet to it, which is a clopidogrel, which further on top of aspirin lowers the risk by 7%. If you give an heparin in a primary health center where you are seeing an acute heart attack, where you can't do thrombolyze, you give a shot of a subcutaneous low molecular weight heparin, further 17% reduction. And if you thrombolyze, a 25% reduction in mortality. But if you reduce the time of revascularization from 6 hours to 1 hour, you'll reduce mortality by 50%. And you can see here, whether you thrombolize, whether you do a primary angioplasty, which is now the state-of-art therapy, if possible, in a short period of time, within 1 hour, then, but if you can reduce the time from 6 hours to, say, less than 1 hour, you will be reducing mortality by 50%. So the mortality for thrombolytic arm will become from 12% to 6%. For the PCI arm, that is angioplasty arm, will be reduced from 8.5 to 4.7%. So that is the power of time, if I can say so, of in acute MI management. And as you saw in those slides, the average time of death was 2 hours, right, from the onset of chest pain or symptom to death was 2 hours. So, and that's true. Not only, I'm not talking of India, even if you see the Scandinavian countries, most of the deaths because of heart attack still happen out of hospital. Once you come to the hospital, we have managed to reduce mortalities dramatically from what was 50% to 4%, 5%, and even in trials where you get the best of therapy to 3%. But these are only people who come to the hospital. Most of the deaths even now are happening to people who do not reach the hospital. So there are certain time targets when you see a patient of ST elevation MI. So anybody coming, making first medical contact, should have an ECG within 10 minutes. And ECG is critical. I as a cardiologist, can tell you any and everybody, including the best of cardiologists, can misdiagnose an MI. So-called gas or acid peptic disorder is so common, but it can mimic MI. And a lot of those gases may actually be gas. So you can never be sure. You need to have an ECG whenever there is a chest discomfort lasting more than 10 to 20 minutes. That's the only way to diagnose. There is hardly any clinical way to diagnose MI otherwise. So it's critical to management. Once you have STEMI, then these are the guidelines. You should be able to thrombolize the patient within 60 minutes. And if you want to do angioplasty, then you have to do it within 90 minutes. And if you want to do angioplasty over thrombolysis, then the delay should not be more than 60 minutes. And time and again, we see in a lot of those hospitals which Dr. Anand spoke of, they insist on doing an angioplasty, but nobody can cough up a sum of 2 lakhs, 3 lakhs, which is the usual cost for a primary angioplasty if you don't have insurance within an hour's time. And then he doesn't get thrombolytic and he waits for the angioplasty, which is such a unfortunate thing, because every minute, as I showed you, you're losing myocardium. So if you can't have angioplasty, get him thrombolized. And what is now called a pharmacoinvasive strategy, which I'll show you, is the other way. You thrombolize and then over the next 2 to 24 hours or 248 hours, you can do angioplasty if the patient can afford and if there is an indication to do that. But unfortunately, what do you see from most studies in India? We still continue to see that the symptom onset to the mean symptom onset hospital admissions still are way above 6 hours. So you really lose a lot of myocardium in that point of time. It's about 2 hours in the Western studies. And so what does that happen? This is from a MACE registry, a very large ICMR registry of acute coronary syndromes. And most of the people are left with weak hearts. So 50%, only 4% was seen to have normal ejection fraction. More than 50% had mild loss in LV heart function. And almost 1 in 5 of the people were left with very weak hearts. And, even if you have survived MI, their prognosis will be poor because they would now be living with heart failure. So the point is, the time is essence, and we need to quickly get these patients to the hospital and give them the right management. And this is from a small study in Punjab. I had worked with Dr. Bishop over there, and they clearly showed that what is of critical importance in early diagnosis and in reducing the hospital time or management of STEMI is a pre-hospital ECG. And if you can able to do that, you can substantially reduce the delays in MI management. So reducing CVD burden occurs at multiple steps. At the base of the pyramid, we need lifestyle interventions for everybody. As Indians, we're all susceptible to, unfortunately, we are susceptible to have coronary artery disease. So tobacco control, healthy diet. We are one of the most physically inactive population. So improving physical activity at a population level. Then the risk factor control, which I showed you, is again huge. Whether it's diabetes, hypertension, dyslipidemia, obesity. Then people with acute coronary syndromes or who have had previous coronary artery disease, secondary prevention. And again, here, if you see community data, hardly 10% of people are on statins, a proven drug in secondary prevention. About 15-20% are on aspirin and ACE inhibitors, beta blockers. These 4 drugs are proven drugs in secondary prevention, but hardly 1 in 4 patients would get any one of them. And of course, top of it is patients with critical disease need revascularization. And why I speak about this is because, and we are fortunate to have knowledge from the Western countries which went through this cycle in the second half of the 20th century. And if you can see, this is where we are high now, probably with very high CHD mortalities, but they could reduce that by 50% in most of these Western countries. And how was that achieved? And you'll be surprised, the 70% of the impact came not from high-end medications or high-end interventions or surgeries. It was by improving, 70% of the benefit was achieved by improving risk factors, improvement in risk factors, whether it be reducing smoking, reducing cholesterol at the population level BP fall by improving on diet. This all led to a cumulative 70% reduction in risk factors. The rest, 42%, was better managing their acute MI by improving their secondary prevention, which I spoke to you about, improving heart failure management. And just about 5% benefit in this model came from doing very advanced things, revascularization like bypass and PTCA. So there is no reason why we can't achieve this, because most of it can be achieved by lifestyle and by drugs, which are very, very cheap and available. And there's no reason why this should not be replicated in India. But currently, the way we do it is obviously not good enough, as you can see from the data shown by Dr. Anand and the data I showed you about how poorly we control our risk factors. So we need innovations, and I'll briefly speak about this innovation that I was part of, which was using mHealth, mobile health, through an app called the mPower, and we tested it first in Himachal in Solan district. We started with these small smartphones. We built an algorithm for managing hypertension, diabetes, and we needed a nurse care coordinator who would be at the OPD, would screen all patients for diabetes, hypertension. This was, if I remember correctly, done initially at 3 CHC level. And then they would enter the details of the patient over there, which was a simple BP, sugar, their demographics, their comorbidities, their body weight, etc. And that would generate a personalized prescription on drugs to give for or not give for diabetes, hypertension. And that would be vetted by the medical officer who would then say yes, no changes, and then the patient would come back to the nurse who would counsel them on lifestyle and make the changes that the doctor suggested. So we when we started doing this, 50% of the people subjects were who never had diabetes, never knew they were had diabetes or hypertension. So that's the power of opportunistic screening that I was speaking to. Half of the people coming to in contact would not know that. And over the 18 months that this pilot study was done, there was substantial reduction, as you can see, by 20 millimeters of mean of systolic blood pressure, and a very substantial reduction from mean of the people who were treated with diabetes medicines. And subsequently, we've had multiple experiences with this mHealth app. We did the large trial, which was done in Karnataka, Haryana. The trial itself was negative, but it was probably because of the enhanced care given in the control arm, which was not real world. I mean, they were getting care which was way beyond what you get in from our experience. Now we're doing a real world study in the district of Punjab, the ITREX study, where it has been, the app has been implemented in the government portal. We ran this initiative for 3 years in NCD clinics at 40 CHC district hospitals, and over almost 2 lakh patients had their management through this app. This is some of the pictures, and this is how the app looks like. It's based on a tablet. So what we saw, as you can see here, it's remarkable reduction in systolic blood pressure and a very good reduction in HbA1c, the patients who were managed with this. So as I said, nearly half of the patients were first diagnosed in our experience. There was significant reduction. And we showed that it's feasible to implement mHealth-based interventions with electronic clinical decision support system built into that in peripheral health centers. And it helps in uniformity of therapy, which is guideline-based. It leads to an electronic health record, and obviously it facilitates follow-up. And remember, this is not a replacement for the doctor out there. It just aids him, it empowers him, the poor doctor who's to manage hundreds of things, including more proximate problems like communicable diseases and all kinds of problems. So he's empowered by this app, I would say, in the prevention and management of chronic diseases, which are not so much of a top priority on a day-to-day basis. And what we saw that there was a very large concurrence with the doctor in terms of the prescriptions generated by EDSS. There was almost 80% for diabetes and hypertension, and the disagreements were mainly because the recommended drugs were not available at that center. So it was a very pleasant thing to know that this was now been adopted by the Government of India NCD portal, and it will be it's being used in the ITREX study and will be launched for all India use, the CDSS based study, and it will be integrated at all levels of healthcare settings, including screening by the ASHA for diabetes, hypertension. So I think that could potentially be a game changer in managing the CVD risk factors at the population level. So the other thing, I think this has already been spoken about, so I'm not going to the detail, is in innovation in acute MI management. And as you know, we need early recognition symptoms. We need ways to rapidly transfer patients to facilities. And we need to improve hospital processes to reduce the door to balloon and door to needle time. That is time to definitive therapy. These are the strategies that are needed. And we had proposed in this paper from CSI the spoken hub model, which was tested as mentioned in the Tamil Nadu STEMI study, which has now been adopted by the government over there, and they've installed, if I'm not mistaken, about 15 cath labs and hub centers, and are doing it quite well. And other states are also adopting that model. In fact, ICMR has also taken up this peripheral health center for this model of STEMI management. But they have provided connective plates, they provided defibrillators to peripheral health centers so that they can thrombolize at first contact, and then the link it to the hub hospital for early diagnosis and for referral. So we need these kind of strategies. This is from one of the districts in Ludhiana where they've linked these hospitals to the hub hospital, which is the DMC Ludhiana. So it has both private and public sector, which is the way to go if we have to manage our patients better. And I really hope that this study shows good outcomes so that can be absorbed into the national program. So my take-home messages for you are that CVD and its risk factor burdens are enormous. I don't need to tell this audience about that. You see it day in, day out, but we need aggressive risk factor management that can substantially reduce CVD burden. The interventions are widely available and proven cost-effective strategies. We need, however, innovations in implementing them to strengthen CVD care at all levels. And I'll leave you with this quote by the philosopher Herbert Spencer, that the great aim of education is not knowledge, but action. And that's where we're lacking. And I hope we do better in days to come. Thank you so much.
Thank you, sir, for such an informative presentation.
Sir, I have a doubt, sir. Like you have mentioned about the Swedish National Diabetes Register. So I'm very interested, and there are lots of
Can I just come in here because I need to leave at 1 o'clock? Is it possible to take the questions at the end, sir? Because I have to leave at 1. I'm sorry about this.
Yes, ma'am, we can do that. You
yeah,
can.
Because it's actually 15 minutes. I know there'll be a lot of, after those 2 great talks, but I apologize because I thought I was leaving at 1. So maybe you could take the questions after the second talk.
Yes, ma'am, it's okay.
It's okay with you? Yeah,
yes,
thanks.
Next presentation is by Dr. Padma Srivastava. She is professor and head in Department of Neurology and chief of Neuroscience Center at AIIMS New Delhi. She was president of Indian Stroke Association and honorary professor of University of Central Lancashire, UK. Ma'am, you can start.
Thank you. And thank you once again. There were 2 awesome talks, and some of it would obviously be a repetition because stroke is, brain is very close to the heart. And that said, you all are well aware of those, this landmark publication in the year 2017 and how the NCDs have taken center stage in terms of both mortality and morbidity. What was important that stroke just rose up to number 1 cause of death and disability in the Northeast and ranks among the first 5 in the rest of the country. So the climb has been really phenomenal, and that somewhere down here, the stroke has just climbed up to number 5 spot. So that's the way we are, that in terms of the numbers, that the stroke statistics are pretty staggering, that as I speak right now, we have 1 stroke happening every 20 seconds and 1 stroke death every 2 minutes. So there we are, we have a double whammy. And the terms of the disability, because stroke is one which is not only killing, it's the cause of disability, which is a life which is obviously worse than death. And the case fatality rate, unfortunately, continues to be steep. This has already been alluded to by both the speakers, and we have our own data, which actually says although the deaths were 8%, in young people. Our study said 16% of all strokes happened in people less than 40 years. And across the country, it's nearly, again, 1 in 5. So let's start with the first case study of a 50-year-old. This is a wealthy businessman, and I've kept these ages much closer, because we're not talking about those ages of 70 and 80. That's not what's happening right now. What we will be more concerned about these young people and the productive age group. So he had right hemiplegia. He recognized it's a stroke. He reached a well-oiled machinery in a tertiary care hospital, and DTN is a door to needle time. So there was a block. The block was identified. It was cleared. He improved in 48 hours, and he just walked back to his life in a month. And now this is a success story. It is happening all around us. It is a reality. But then look at another case study that there is a 45 years old. This is a shopkeeper, and he also had a stroke. And this person is about 60, 70 kilometers. He's somewhere in the probably at the edge of the maybe in the states beyond Delhi. And then he hides a local taxi. He goes to a district hospital. There's no CT scan there. So he then goes to a private CT center, comes back to the district hospital about 12 hours into it. And then he's told, oh, okay, you have had a stroke and you take aspirin, be a good boy and don't smoke and take your BP medication. The guy goes back with the stroke. So the wife becomes a caregiver, and the son drops out of the 10th standard and looks after the shop. And ladies and gentlemen, this is a reality as well, and it is happening all around us. So when we mapped out the current status of stroke care in India, besides all those things, and I told you, I'm not going to repeat what has already been said, which is true across all the NCDs, whether the risk factors causing those NCDs and the big five, those NCDs, whether it's the heart, the brain, the kidney, the lung, whatever. So you have a delayed arrival, lack of awareness. What's going to happen more so with the brain, because more people are aware of what can happen with heart and very few about the brain. And then they, unfortunately, when you in the stroke chain of survival, you also have some interest when you don't know in the academia as to the advances which have taken place in stroke. And then that leads to some of those unfortunate issues as well. And economics always play a huge role. So when we looked at the treatment gaps within India, and we looked at one parameter as a measure of understanding how robust is our stroke chain of survival, we found a dismal rate of thrombolysis. It was just 0.5%. And let me give you a perspective that in the best of stroke centers in the world, and it's about 33%. And even in a well-oiled machinery, like say in AIIMS Delhi, our thrombolysis rate is about 19.5%. So there is a difference between even the centers catering to stroke across within our own country. The 24/7 availability of a physician who knows, understands what stroke is. I'm not talking of neurologists. The use of stroke maps, and of course, the implementation of stroke care pathways, presence of a stroke unit, a stroke team, and of course, even the public emergency ambulance system. Each of these have been realized to be chinks in the stroke chain of survival. So this is 2016 publication where about 40,000 in a year could be thrombolyzed, but well, just 0.4% did. And when we mapped out across India who all were actually stroke ready in terms of public sectors mostly, but also the private sectors, and we found that in terms of thrombolysis, this is exactly what it was. Okay, so in the across the whole country, if you see, you have large sections where we don't have data. We've been able to get more data right now, but then still it is an issue. And between 2009 to 2016, there's been a big advancement in terms of even thrombolysis rate per se. In the entire year, if it was 1,700 thrombolysis and you have 4,500 strokes happening each day, you come up to nearly 13,000, and this has definitely grown. So that's been great. And when we also mapped out what are all the issues to be looked into and looked at the networks which need to be connected. Now, each one of them can't be a silo. But each one of them, when developed and linked to as a network, it did lead to a great improvement. And I'll just come to that a little later. So in the messages which we try to give to the NPCDCS program, we are part of that, that this entire stroke care pathway need to be addressed to in terms of reduction of the burden of stroke. Yes, that's where we have the prevention modules, and those pillars need to be strengthened, and they are being strengthened because they're common in terms of heart, kidney, lung, what have you. So you have that as a big pillar, that you don't want hypertension, we don't want diabetics, we don't want them to happen, we want them to be controlled. But as is being said, while that is being done, the outcomes do happen, the organs do get affected, and for that you need an assessment, care, prevention, primary, secondary, rehab, and disease surveillance. So the regimen, as I said before, the first thing, in fact, this was an interesting anecdote I want to share with you. In the year 2014, 13, in fact, when we took up this program and we had approached the authorities and said that the stroke care under the NPCDCS program need to be spruced up. It need to be actually tweaked a little to make it much more in line with what is happening in the world. And so they said, what exactly is not happening? So we said, we're not having thrombolysis happening. So it was a revelation of sorts, because it was not known that just like heart, when there is a blocked artery, you can unblock it. Can you do the same with the brain? And this was when 1995, the first thrombolytic drug for acute ischemic stroke was already approved and launched in the world market. So therefore, we came a long way from there. And we did get in right now in the guidelines. In fact, we just updated the latest stroke guidelines by the Ministry of Health, and as well as from the DGHS office. Just a week ago, we formalized it. This was the 4th edition. I'm an author of that. And the thrombolysis and thrombolytic drugs have all been there. Good. And it is actually being covered free of cost. And that's a great thing again. So in thrombolytic agents, we have 2. We have tenecteplase, which is a great thing, which is again has happened to the developing world. India has been a prototype. We have this, we use this extensively. And we also have certain protocols where we say, okay, now this looks like a Ramban, but don't give it and just vanish from the scene. We do have some monitoring, but this is not a rocket science. This can be done by a physician who can manage an acute emergency. So forget about this awareness, and this we've done it. We need this sponsored emergency ambulance services, absolutely. And from a public health point of view, ambulance facilities definitely need to be spruced up. I'm so happy that there are states in this country where they do exist nicely. Delhi still has to have that. Now, between the bridging the gap, you have around, now this has grown, okay? 1.8 million stroke patients is not true. Now it's more than that. And we are around 2,500 neurologists. Now, it's not a neurologist who can manage a stroke. That's a no-brainer. So we've developed the standard operating protocols, and those, in fact, I call them monkey-proof protocols, wherein if in an emergency system in a district hospital, you have the emergency doctor who manages delivery or trauma, you have an acute heart attack as being, Dr. Ambuj has so well described. Why not stroke? Now that's a brain attack. So therefore, we develop these. And when you're looking at a number needed to treat, ladies and gentlemen, within 4 to, you within 90 minutes, if you can unblock a blocked artery in the brain, just treat 5 patients, you will avoid a death or a major disability. That's a humongous biological benefit. Just compare this to giving 1,000 patients aspirin to get the same benefit. So there's a huge benefit. And this again, it's very logical, isn't it? There is a blocked artery. You don't unblock it. There are zillions and trillions of neurons which are lost forever. You do need to do that. And when people have looked at what is a single intervention to get this time metric in place, that there is a stroke, you're getting your thrombolytic there intravenously. And when they did that, they found that it is very importantly triaged in the emergency system. Yes, we need people to come. And there was a beautiful question by a very intelligent person in the audience, and I was listening. Yes, we definitely increase the public awareness. And when they reach the emergency, if you don't have your systems in place in your hospital, that's tragic, right? So all these things needed to be seen. And the best practice strategies are well laid out. This is across most geographic centers across the world, but we need to look at practical aspects and what are the guidelines there. Okay, so we did look at into these steps, whether, which is the big rate limiting step. Is this the recognition? Is it the CT, labs, the neurologist availability, the radiologist availability? Well, you can actually go through all of them and you can surmount most of those. And telemedicine now has come as a big way, and especially in the COVID times, this is one thing which has become pretty robust. And we looked at the coagulation parameters. Initially, they said, before you thrombolize, you please get your PT, INR, platelets, everything within that very narrow therapeutic time window of 3 hours. At that time, it was 3 hours, and now it's 4.5 hours for intravenous thrombolysis. So we went around it. In fact, we were the first ones to publish a thrombolysis data from India. And we did not wait for our PTNR. We carefully chose the patients. And now 2018 international guidelines say you don't need those things. Okay, you don't need to factor into your narrow therapeutic time window that the patient has come to the emergency, that you need to send out this blood coagulation parameters and wait for those reports to trickle down and then you thrombolize. So similar to the apps and similar to the IT technology, Himachal seems to be the first launching pan for most of these, as I understand. So we also did that. And this is a beautiful little state, and we didn't touch Lahul Spiti. That is a completely different mountainous terrain, but the 10 districts which actually had the CT centers, we designated them as primary stroke centers. This was launched in 2014. What we did is a top-down approach. We made a WhatsApp hub and spoke model, and we made the thrombolysis drug free of cost and on the bench in these district hospitals. And we connected by a smartphone, and this was a no-cost model. Basically, in the WhatsApp, this is how a CT scan looks like, and we trained them like, whenever you see something dark or something white, don't thrombolize. It was almost like monkey proof. We gave the standard operating protocols there, which actually did not include huge infrastructure. You needed a smartphone, you needed a BP machine, and you needed a point of care but blood sugar. And ladies and gentlemen, the first thrombolysis for acute ischemic stroke in Himachal was actually done by an orthopedician who was manning the emergency. And this, in fact, we have published, and this has been taken up both by the government of India as well as internationally. It's been recognized as the one which is a low-cost model in a developing world where you can use the IT technology, and without the neurologist, you can get the first thing where time is brain. So in the components of stroke unit care, besides the diagnosis, managing, rehab, assessing the discharge needs, and the various, the parameters which will actually help you to audit the performance measures, there is always a great enthusiasm to go and launch something and then forget about it. So you need to have this periodic audit of the a priori set performance measures, which will then help you look at the time matrix, what's not happening, and then clean up that act and have an upward mobility of your plan. So we know that in the, most of you would know better than I'm a neurologist and I'm a stroke physician, stroke clinician. But you know better that in terms of healthcare delivery system in India, we have a hierarchical system, we have a primary, secondary, and tertiary care system. So we've actually mapped out how stroke care can be given in these three different hierarchical systems of healthcare delivery. And we found that yes, in primary, it is more often than not prevention. You can still have a rehab, and you can have awareness and shifting to a better center. But in secondary, that is a district level and beyond, and a medical college level, you can do most except probably surgery. And tertiary would be the comprehensive centers. So we mapped out this across, in fact, most states in the country. And we've launched this in a lot of states, and it's been said in Uttar Pradesh, in Rajasthan, and a lot of them. In fact, the game plan being getting the right patient to the right place at the right amount of time. And this is again, the World Stroke Organization is always this blessed pyramid, which keeps it, appearing as to what stays at the bottom and what's there right up. And don't have your priorities where you flip the pyramid and then you'll fall flat. And the stroke units are there to turn chaos into order. essentially the stroke units are those, it's not again a very high-end infrastructure or high-end personnel. It is a group of people which actually includes a clinician, rehab, nursing, who actually can preempt a complication from happening and prevent it and treat it early. And in this, you have basically treatment of blood pressure, prevention of infection, prevention of aspiration, and simple FES protocols. These need to be implemented, and you would be really surprised that even in the best of big public care hospitals, it's neglected. And we've also launched a mobile stroke units in Northeast, and this is part of the ICMR and Professor Balram Bhargav's initiative. It's been there, it's running, it's really nice. In fact, the last thrombolysis in the MSU was done just yesterday in a remote place in your Tejpur. Great things going on there. We've also organized a lot of awareness, and we've also developed another app. This was developed in Himachal again, where it actually gives you your risk score and how to reduce the risk score. Now, these risk score or riskometers are available outside for a price. This we've launched it, but unfortunately, people were more interested to download Amazon apps and Myntra.apps, and they were not really interested in stroking. So that's again, the attitudes. So we do have these things, programs out there. The last part of it is rehab, because in spite of what you do, there would be disability. And I was telling you, disability is one of the biggest bugbears after a stroke. And so more often than what happens is that you have this, people do improve, they go out of the hospital, the rehab is not there. Rehab is, getting somebody home and doing it for you is extremely expensive. It's not going to be practically feasible to most. And you know that, and all of you sitting there will agree with me, and we all share the same goal. Health is not a luxury, isn't it? Health is my birthright. And for every citizen in a civilized society, health can't be bartered to haves and have-nots. It has to be optimal. The optimal healthcare needs to be available, accessible, affordable to all. There are no barriers of economic, geographic, or social, systems there. Hence, therefore, rehab is such an important thing. So what did we do in this? We try to incorporate the local systems. We did that with Amchi doctors in Ladakh. We've done with, the local doctors in Himachal. Give them the respect and get them into your fold. And apart from this, of course, you have the yoga, you have other systems in Ayush. And this is, been there, and people are doing this. And yoga, by the way, is a way of life. It's just not asanas or some breathing exercises. This is what Swami Vivekananda said. Now, this part I'm skipping because there's been a lot of encouragement in terms of advances and research, wherein India has been at the forefront in a lot of stuff. But this is the last couple of slides that I would end with, that may not be really directly translatable to NCD straight away in terms of public healthcare delivery. What I'm trying to get here is that when you're looking at several disciplines, now we are bridging them. You have clinical medicine, you have public health, you have IITs, and you have string mathematics. So you are actually bridging them, because when you're bringing in different disciplines together to address a common question, you will be able to find that answer. So we're developing our own robotics, which costs probably 3 crores outside, and we are getting this in barely 1600 rupees. And this, if it is able to develop, and this we will be able to give at a district level, whether it is non-invasive brain stimulation or these things, this will also add on to the rehab potential. And just like we have the IT sector, wherein we are bringing in this, several other ways of finding solutions to the problem. So first is mapping, addressing them, launching an implementation module, but then also audit at the end at periodic intervals whether whatever you implemented is giving you the results, and then take an upward mobility to the same thing. That's it, Canada. And this is my last slide. Never ever give up on your stroke patient. Thank you.
Thank you, ma'am, for the presentation. Any questions?
You can always ask questions to Dr. Ambuj. Some of them want it.
Okay, ma'am. There are no questions, I think.
Thank you, Dr. Padma, for that talk, and I think providing a lot of encouragement to the and motivating the group. Thank you.
We will be having.
For online delegates, we'll be breaking up for lunch. See you back in by 2 o'clock.
Okay.
So good afternoon, everyone. Basically, I'm a clinician who runs two endocrine clinics or oblique diabetes clinics at AIMS Delhi, and run a specialized clinic in diabetes and pregnancy once a week. So I do my research interest is basically a health promotion. So I am involved in the randomized controlled trials of health promotion for last couple of years, and have a bit of involvement at the health system level research. So basically, I will be combining the experience from three different entities to make a presentation before you. Okay. So let me start with the two cases who have presented this Monday in the clinics. So just you give a glimpse or lay a background for this presentation. The case one, these are the real cases, right? So case one was a 26-year-old male who was a resident of Bihar, was a newly diagnosed diabetes. Basically, he came to AIMS for bipolar disorder, and the physician just ordered a blood glucose test and was found to have a fasting of 342, for which he was referred to the endocrine clinic. Since he was 26-year-old male, the probability of type 1 diabetes remained high because he was thin built. So he was initiated on insulin because if fasting is more than 300 and the patient is having youth onset diabetes, so it is preferable to start on insulin therapy. So once we start on insulin therapy, there is a lot of education that has to go, because once is a insulin, then there is a diabetic education on diet, exercise, insulin technique, sick day rules, hypoglycemia care, blood glucose monitoring. So it's really a package of a massive sort of information to a person who is not aware at all. And especially at a stage when he's stressed with the new onset diabetes. So it's a very high degree of stress to the patient. So we said, okay, we are planning to start on insulin, which patient and the relative agreed. And we asked him to follow up after 1 week. But suddenly the patient said that they are returning back to Bihar the next day. So the question comes like the quantum of information that has to be taken. So usually we follow this patient every week or alternate, means every fortnightly. So there was a little worry what's going to happen when he returns back, how he's going to comply, and how someone is going to take care of these sort of things. Because apart from chronic complication, there is an imminent damage of a diabetic ketoacidosis, which is an emergency in diabetes, and there is, if not properly treated, 3 to 5% mortality. So this is one case. Then this was the same case again, which presented to the Monday OPD. This was a newly registered patient with type 2 diabetes, 65-year-old male. He was diagnosed 22 years back. That means at the age of 43 years. Now he presented to us with the all sort of complication, chronic kidney disease. He had pedal edema. You can see his swollen feet. Then he had a PDR, means vision was markedly deteriorated in this patient. The PDR is proliferative diabetic retinopathy, advanced stage of diabetic retinopathy damage. Then he had severe neuropathy, was not able to perceive, means
have no sensations. There was a history of slippage of chappals, and he had a diabetic foot, as you can see, infected. And this infected foot is present for last 2 or 3 months. So from Bihar, he has to travel 2,000 kilometers just to get treatment for this illness. So when you see such a sort of patients, and these are like patients we see day in and out in every OPD, these sort of patients present, and at the same OPD there were 4 or 5 patients from Bihar that came as a new registrations. So when you see this patient, these are the common questions that come every time we see this patient. Why he is in such condition? Because diabetes is a preventable disease, means at least complications can be prevented. At an early stage, even we can reverse. And if it is a pre-diabetes, we can prevent from progression to diabetes. So it's a preventable sort of things, and the patient is landing up with such sort of bad shape. Then why he has to come to Delhi from Bihar with this condition after traveling 2,000 kilometers? Now for this, so he's lingering with this foot for the 3 months, and still there's no improvement in the situation. And then if I treat them, okay, we admitted this patient on the same day, thinking that he's from outside. So even we treat them, like what sort of situation will happen post discharge, whether patient is going to come on a regular basis to Delhi, or we have some place to refer back where he can be treated. So these are the common questions which as a collectively, as a clinician sitting at the higher end, and the people who are working at the grassroots level has to be connected, so that we have solution for these sort of patients, and we can decrease the misery associated with diabetes per se. So with this background, let's see where we can improve the outcomes of these patients. So there are some patient related factors, there are some health system related factors. When we say patient related factors, had this patient be diagnosed early, maybe at a pre-diabetes stage, right? So we can completely could have changed the natural history for this patient. This means screening is very important in diabetes. More you screen, earlier you diagnose, earlier you treat, you can avoid these complications totally. So this is a one core area which has to be focused upon. Then when we plan a management plan, there is a behavioral modification. When we talk about behavioral modification, there is a diet. Just not restricting the elements of any particular nutrients. There are a lot of concepts, in diet itself. Right, very simple concept, but still patient doesn't comply to that concepts. Then there is a physical activity. What we ask for, 30 to 45 minutes of walk, but the data from even Dr. Anand's paper has shown that the physical activity level is too bad in the Indian context. Then about treatment adherence, there are simple 4 or 6 medication everyone can prescribe, everyone can titrate. There's nothing too complex in the diabetes. Limited number of medications easily can be done. So we prescribe medication, we just ask patient to be adherent to that medications, right? And then we ask that patient, depending upon the situation, to follow up regularly. If the patient is well controlled, we ask after 3 months of follow up. If there is something acute, has case 1, DK, youth onset diabetes, or such patients or diabetic foot, we may ask patient to come 1 weekly or 2 weekly, depending upon the situation. To follow up can range from 2 days to 3 months for a poor patient to a good patient, right? And then whatever you ask to the patient, it's not only the glycemia, because if this patient has been screened properly with the complications, has been educated, he would have avoided the diabetic foot. So you need screening for neuropathy. He was diagnosed as a PDR. There are hell of stages before mild NPDR, moderate NPDR, then early PDR, then late PDR. So the patient needs complication screening, so it's picked up and treated at a right stage. So this is another follow-up that is required from the patient, and this is annual. If even annually we screen, it is well and good enough. So for all these condition patient-related factors, the element is that awareness. So if we club that things, so these all 4 things need awareness at the patient level. This is one aspect which need to be strengthened. Then we come to the health system level factors, because it's equally important to the doctor where he goes. If he has to come from Bihar to Delhi, there must be something wrong at where the place he is taking treatment to. So the training of a particular doctor at a grassroots levels is very important, so that he can provide the right treatment to the patient at the right stage. Right, then it's not like a solo person taking care of a patient, it's a team effort. We have a diabetes educator who treats all this insulin technique, because we also see 100 to 120 patients in a single day. So we can't do all sort of elements of care with a single person. So we have a diabetes educator, 2 or 3 educators, which treat patients of all these aspects, what I elaborated with the case 1. Then we have a dedicated dietitian which takes care for the diet advice. right? So you need a basic sports staff, and you need a basic facilities, because you need a fasting, PP, A1C, what sort of a lipid profile or LFT, RFT at a regular interval. So you need a basic facility so you can titrate and just screen for the comorbidities or the means complication zones. Right? You need some specialized services, maybe a fundus, maybe a neuropathy screen, maybe a nephropathy screen, and some sort of specialized facilities which need to be there at the health system level, so that we pick this patient and diagnose everything at the right stage, so that patient doesn't land up such sort of situation as I elaborated in a diabetic foot case too. So overall, if we club this needs a good infrastructure which can provide from the health system level to such patients. And I think this will be the focus of this presentation, how we can improve at each level and with our own different expertise. So let me show this slide, and I want to highlight why this diabetes is important and why we are here to discuss this entity. So this is a national non-communicable disease monitoring done in India, pan-India level. And Dr. Nand was one of the core investigator in this. So it was accomplished in 2017 to 18. It shows a prevalence of 9.3%. And before that, there was a paper published from the ICMR INDIAB study from 2018 8 to 15, which said that prevalence of diabetes is 7.3%. It's not like 1%, 2% increase. If we see it's too meager. But 1% increase for India means 1 CR of patients are adding every year. And if you add at the district level, roughly taking 500 districts, means every district is adding 20,000 of patients each year by 1% increase in diabetes. So means 20,000 of patients and 25 to 50% land up with complication. You can just see the burden of patients with complicated diabetes, which are going to add every year to our means already burdened system at the district level. Right. Second thing that is worrisome, that 50% doesn't know that they have diabetes. 1 in 2 is undiagnosed. Right. If it is undiagnosed, means untreated. Untreated means the patient is lingering towards the complication without any attention. Third part, even 50% who are diagnosed, only 33% are optimally treated. Means there is a 67% who are not achieving even A1C less than 7%. Now with the current drugs, we are aiming even at A1C of 6%. 7% was when there was a metformin sulfonylurea. Now with the safer drugs, we can aim around 6% even in the elderly. So there is a change of spectrum with the available of the medications. But if we talk even by the 7%, this means if we translate every data, only 1 in 6 is practically controlled. 5 out of 6 are either uncontrolled or undiagnosed. So this is a ground reality in the diabetes state. Then there is a graph at the right-hand side, which shows that red is a diabetes prevalence. You can just see with the age, the diabetes prevalence is going to 25 to 50%. This is a data from Delhi, may not be translatable to all sort of states, but it shows that where we are heading towards. So it shows that with the aging population, we all know that India is aging. So with aging, the prevalence of diabetes is further going to increase, right? And the fifth part, which I want to highlight, this is a young persons, the prevalence of diabetes is low, but 50% pre-diabetes. If we don't detect, we don't promote health, this will go progress to the diabetes and subsequently to the diabetes complication. And you can just see the burden which is going to add in a near future. So these are the 5 points which make us worry about the diabetes system. So screening prevalence is high. We saw that there is a high morbidity and mortality. The long lag period, because diabetes is asymptomatic for number of years, means it's said that patient can be asymptomatic even till 5 to 10 years before he manifests symptoms of diabetes, going into the catabolic state. So it's a long lag period even when the patient manifests diabetes, and obviously there is a pre-diabetes phase, means of a marked duration, where we can pick and change the natural history of the diabetes. So this disease is amenable to change its natural course. And the test for diabetes diagnosis are very easily available. Glucose is one of the basic tests and a low cost. It hardly costs 7 to 10 rupees to the lab, even at the best of the institution. So even if I screen 10 patients, means 100 rupees, I'm going to detect at least 1 patient minimum of a diabetes. I think it's very a cost-effective investment of screening in patients with diabetes. Means 10 patient, you conduct a camp, 500 patient, you are like 25 to 40 patient at least you are going to pick. And if you are going to channelize the 25 to 40 system to the healthcare system, so you can change the natural history of the diabetes for such patients. And the treatment or complication costs are high. So we know that at the health system level, please ignore if I'm wrong at when we talk about the health system level. What I understand, there is a home screening at which ASHA worker or at least ANM is entitled to do this screening for diabetes every year above 30 years of age. There is a provision in this national program where opportunistic screening has been talked about. Right. Beyond that, what we can do is like a special camps by the NGOs or as a part of a corporate social responsibility or by the government itself, where we can change. Means in future, first we have to implement what is there in the guidelines, but we again has to think about the future, because 20 to 30 again the burden of pre-diabetes is very high. So it's better to like focus in the near future to screen every adult above 18 years, because lot of the surveys which I mentioned or has been conducted is in the adult. It doesn't start in 30. Most of the surveys start in 20s, and it is shown that there's a good burden of diabetes or pre-diabetes even at the 20 to 30 part. And this is what we recommend, like 6 monthly for a pre-diabetes follow-up and 20 monthly for a normal. Again, there is one thing which I want to focus to the nodal officers, like glucometers, right? Obviously, government is like lower bid, means whatever the things is a lower bid comes into the system. But we again have to think about the quality. It's a MARD. MARD means like what is a variation from the reference interval. So glucometers, wherever we use, we should try to use a standard glucometers wherever we can do so. So the variation of from the reference value is not more than 10%. This is one which we have to keep in future. And obviously, we have to generate more of awareness for the screening through media or by using the peer leaders or the family leaders. I just wanted to highlight this study. Why I'm going to highlight this one. This is like I do research in diabetes and pregnancy. The women with hyperglycemia and pregnancies follow. So what happens? We see that after delivery, there is a poor social support system to the ladies. Means with the child, they find it difficult to come to the healthcare system. So we thought about like involving spouses, right? And then we talk about like diet, activity. There is a lot of blame game given our social structure on the ladies. So we did in a research mode evaluated spouses for cardiometabolic risk factors during 24 to 32 weeks during pregnancy. So when we screened spouses, we found that 53% of the spouses of these ladies had dysglycemia. Means 7% had diabetes and 46% had pre-diabetes. And the mean age of men was 33. So a slide which I showed earlier, 50% pre-diabetes, we found that the data is almost correct, because in an independent study, we say that 50% have pre-diabetes or diabetes part. So this is a research which says opportunities, because there is a strong healthcare program focused on maternal health, right? So there is no such program where the men is so closely followed up by the healthcare system. So this was like just one in the future where we can aim that if ladies following up, if we can just opportunistic screen the men at that young age, and this is a load we can pick and can change the natural history of many of such patients. So going to the management part. So what's the existing management practices? We have a MBBS persons or with the alternate degree or MD level persons who are managing the means CHC or the PSC or the district hospitals, which are already burdened by a huge number of patients. So there are guidelines for them with the titration algorithm for diabetes management, which says that there should be a periodic escalation of doses. Like every 3 months, you increase the dose to control the diabetes. And there is nearly same approach for every individual. And the guidelines are basically framed concentrated on management with limited resources, and metformin and sulfonylurea are the two drugs which makes part of these guidelines. So just to give you a glimpse, like how fast the guidelines change or how the concepts change, and we should be aware. It's not like pure scientifically, and just giving you an example from the guidelines, why it's important to be dynamic rather than static part. And this is a guidelines from American Diabetes Association, which is give guidelines every year. So it's 2014. This was a guidelines. The approach was that if you start monotherapy, one drug, wait for 3 months. If the patient is not controlled, move to 2 drugs, wait for 3 months. If not controlled, move to 3 drugs. This is approach. Then 2016, the same approach, but there was addition of one drug, SGLT2 inhibitor. So there was one additional drug which has entered after 2 years in this portfolio. The approach remained same. Then in 2018, again 2 years, they understood that it's like it's giving sort of long period. If one has been having a uncontrolled glucose, if you move step by step, you may take 12 months, 18 months to come or treat patient to the target. So let's say you see what is the A1C level at starting, and you can use 2 drugs or 3 drugs or even insulin at start, so that patient is controlled earlier. So by step approach, it means sequential approach, the approach changes to the combination. Means start drugs earlier with a combination so that patient can be rendered euglycemic at the earliest. And then there was also a changing concept. The drugs was initially meant for only glycemia control. There was like a drug which suggested that there are means benefit beyond glycemia. For example, in atherosclerotic cardiovascular disease. So there are drugs which can be chosen based on that profile, that if patient is having CAD, you can choose this particular drug. This is 2020, which individualized further patient, that if the patient is having atherosclerotic cardiovascular disease, you choose these drugs. If patient is having renal failure, you choose these drugs, because beyond glycemia, patient can have decreased renal progression. Right? Then if it is hypoglycemia prone patient, choose this drug. Weight obese patient, choose this drug. And on cost basis, you can use metformin and sulfonylurea. So what I mean to say that from monotherapy to sequential therapy, and from a single approach to an individualized approach. So with these guidelines basically rapidly change. And the third concept which I want to say is a suboptimal glycemic control. Where there's suboptimal glycemic control, one is a non-adherence from the patient perspective, and second is a clinical or therapeutic inertia, that patient needs escalation of drugs, but the clinician is reluctant to escalate the drugs. It has been seen that most of the patient doesn't get euglycemia because of the reluctant at the doctor level. So they don't escalate the drugs as desired, so that patient can be rendered euglycemia. So why I gave you this background, because this is a iTrack is a program which is at the system level. This is a major program which is being taken by the Dr. Nikhil Tandon, who is a principal investigator, along core investigator, and I am part of this program in the clinical decision support system. So this is program which is aimed at modifying the health system level. So I just show what changes this program is aimed at. What we did is we built a clinical decision support system. We built a program where we incorporated all guidelines in a software which provides take inputs, means on the basis of glucose values or A1C value, whatever the values is available. It takes input from the existing clinical research, this case record form, which is available in the government portal. Take the inputs, process, and give the output. Okay, if this is a level of glycemia, if this is a drugs which patient is taking, you escalate these drugs to this much, or these are the options which you can give to the patients. It's very advanced clinical decision support system, which is, and the one thing is it is independent from the government survey. It is integrated, but is independent. So it can be easily integrated or easily modified even outside the government system. If there is a new guidelines, it can be easily modified in 2 to 4 weeks, incorporating new rules, new guidelines, and again can be synchronized with the government health portal system. This is very advanced sort of clinical decision support system which we built based on our understanding that there is individualized approach, there should be a flexibility in change in algorithms, and there should be need to break the clinical inertia at the clinician level, so that means optimal management can be rendered to the patient. The second part which this iTrack is working on is a task shifting. Because initially the government level portal is basically wants doctors to enter all the details in the system, capturing all NCD details, so that information can be gathered and then processed for some meaningful conclusion. So another aspect of this program is a task shifting. What happens in this task shifting? This program entails or gives nurses, paramedical staff, where the patient comes to the clinic. A nurse enters all vital details, all blood glucose values, everything that is required for a management perspective. Then the CDSS gives the prescription, which the nurse can take out, print out, can take to the doctor, and the doctor can see whether this prescription is right or something need to be modified. If he agrees, then the prescription is given to the patient. If he disagrees, the amendment is done in the CDSS and the revised prescription is given. So whatever the information doctor needs is already available in the system, is already available in the printouts. So it takes information for the last 4 or 5 visits also. So it takes all sort of spectrum of information so that doctors can process and quickly give a decision which is evidence backed by the evidence-based guidelines. So how this system CDSS changes the existing system, because at PSC level at the moment only 2 drugs are prescribed by the physician. This system basically enables a doctor to prescribe more than 3 or 4 drugs which are evidence based and in a safe manner. And it also has a provision where the insulin titration guidelines are incorporated in the system apart from the oral drugs. So it also takes into account the contraindications into system, that if there is some contraindication, chronic kidney disease, so it modifies the prescription depending upon that, and it incorporates all sort of means drugs in the algorithm, so that there's a flexibility. Like if there more drugs are available in the system, so the system, this CDSS is capable of handling that part also. The another thing which we need to means think about, especially at the persons at the state nodal officers like that, which we need to think about, is a specialized and multidisciplinary service units. How we can strengthen the care at the apex level. So the patient needs means complication workup of fundus, renal, this heart and neuropathy. So it's not only important that these facilities are available, it's also important that facilities are available in a coordinated manner. For example, if a patient is coming to the district hospital for 1 day for cardiovascular assessment, another day for fundus examination, 3rd day for nephropathy, and 4th day on neuropathy, that person is obviously going to lose contact with the healthcare system. So it's important to build multidisciplinary units where all doctors or all facilities can be kept on a single day, so that when patient visits to the healthcare system at the district level for screening, so that the fundus, neuropathy, everything is done at one go. And if doctors need to be treated, all doctors can be available as a team on 1 day, so that everything is done under one roof and under 1 day. So more convenient is the system for the patient, more is a compliance with the patient with the healthcare system, and more are chances that optimal management will be delivered and patient can be retained with the healthcare system. The second thing is that we also need to think about that the patients we are talking about are poor patient coming from villages who have to travel, like there are logistic issues. Because I was talking like one of the PSC officer when I was interacting, he says that's a bus aati hai, the bus comes at 11, like we were talking about fasting, getting fasting glucose at 8:30. He said there's a bus which comes from a village, the bus comes at 10:30. Then the patients are in hurry because that bus has to go back at 12:30 and 1 o'clock. So we have a glucometer, we just do whatever is available, and even glucometer I have to purchase from my pocket. So this is a system which we need to think about. So this is another has a nodal officers means at state level where you can think or discuss. Think is that we have heard about the mobile blood banks or mobile mammography van, right? But I have not seen or anything like this diagnostic diabetes mobile van. Right, so there could be some sort of provision where, like, because the instruments that are used for a diagnostic are very handy, they can be put into a one lab, and we can do, like, for example, if it is a CSC, okay, this week this CSC, and there are 5 or 6 PSCs, so Monday van goes to this PSC, Tuesday goes to this PSC, Wednesday goes to this PSC, so that the delivery of services are delivered at the doorstep to the at the village level. So you can just see the if the van is reaching at the right time, so you can the compliance with the screening part can increase, and it's a lot of time saving or money saving for a poor patient. So this is one concept which we need to work about in futures. And third is that, again, I showed that there is individual provision of screening of diabetic complication, but we don't have even integrated clinics even at the apex hospitals. For example, we run pregnancy clinic, but we don't have a diabetic food clinic. PGI Chandigarh runs a diabetic food clinic, but doesn't have a pregnancy clinic. Right? So people are individually level try to see and work upon based on their interest, not from a requirement point of view. So given that such sort of patient which are lingering here and there, so we need to think about and have a specialized clinics, for example, a pregnant women, for a youth onset diabetes, which have a different sort of requirements. And third, such sort of patient diabetic food, where patient knows, okay, this is a diabetic food, here you have to go. Right. So these are the things which has a we have to envision and see if these exist in real time in future. So I think I will just skip health promotion. Health promotion, one concept, we conducted a large trial in a women with a postpartum gestational diabetes, in which we trained ANMs or facilitators in 3 nations at 20 centers. So when we see that, like, you recruit one trainer, 6 months later the trainer goes, you have retrained the patient, right? Then you don't know like which trainer is going to give your material in what manner. So there is a lot of heterogeneity depending upon the facilitator's knowledge level or facilitator's level in delivery of the content. So this COVID, we have seen the boom of means virtual things. So this is one area where we can build health promotion videos, means which are like have a backed up of, means seen by the expert persons, have been validated, and then can be delivered by the audio visual aids at the ground level, so that health promotion things can be facilitated. So just to summarize these things. So what I need or wanted to lay focus is screening. Screening is very important. In whatever manner we can increase screening, or has to be promoted. Then we have to need a strong clinical decision support system, so that the clinical inertia can be broken for the physicians, and the system is capable of have a flexibility of rapid adaptability to the changing guidelines and delivers the best model of care. We need to envision where the people of PSC or CSC are capable of handling all patients who are on oral drugs. In CSC are capable of handling all patients of oral plus insulin. At district level is capable of handling all complicated cases. And there are specialized units, at least one in the district, where people can go for a specialized care, for example, diabetic foot. So with this, I will end my presentation and will look forward to have your views on means what system exists and where we can improve further from a strengthening diabetes care. Thank you so much. So we need just a fundus camera. It's like this much space. You can handheld fundus camera is available with 1 or 1.5 lakh, I think. Then there is a neuropathy instrument. Now even there is a handheld neuropathy instrument just of this size, again about 1 to 1.5 lakh. Then you need you can do a urine spot albumin crate ratio. There are ready-made kits which are now available, right? And by time it will become more accurate and more cheaper. And then you simply need a ECG and for a cardiovascular assessment or blood pressure, right? With basic test, glucose, A1C, lipid profile, even not A1C, glucose or lipid profile, because dyslipidemia is one associated comorbidity which has to be corrected. So everything can be like fitted into even like a single small sort of van. Any other question from participants?
Sir, my question is, what are the alternatives we can consider to avoid dependency on a specialist to identify complications of diabetes?
Avoid?
To avoid being dependent on specialists, ophthalmologists and neurologists to identify complications. Like, can we increase the competency of general doctors?
Obviously, that should be the aim, because training has even at the PSC level, people are more trained, more capable of retaining patient at the ground level. The same patient not has to linger with multiple specialties. So that should be one aim. Strengthen at the grassroots level so that they can retain patients at maximum patient at their level, but with efficacy. So that should be the aim. Every that's what I culminated my slide at PSC. People at current level, you say that if patient is on 2 OHS, you refer for the third OHA to the CSC or district level. This is not required with the current sort of medications, because CDSS is giving you safe advice. Clinical decision support system is giving you an accurate device, evidence-based advice, which we follow in the tertiary care setting. So if the system is giving, you just have to see and implement. So the most of the things which are handled at the CSC and the district level can be easily implemented at the PSC level with the current adoption of the technology. That is what we are aiming at. So clinical decision support system is, I think, which we are building and is testing at Nawashahar in one of the district at Punjab at health system level. So that is fairly advanced sort of software. With that, most of the doctors should be competent enough and retain maximum of the patients.
Sir, one more thing. The software you told, the clinical decision making, is that openly available to everyone? Or like,
yeah,
that software, clinical
software is basically for the government. This is this iTrack program is at the health system level. So what it's saying that software is being implemented at PSC, CSC, district level. It gives the threshold for referral from when to refer PSC to CSC, also CSC to district, and when district back to CSC, same to PSC. So it's a health system level. It's in an advanced stage. A ministry is involved in that software.
Okay.
So hopefully in near future it should be a part of a government of India part.
Thank you, sir.
So this is in regards to the drugs that we are giving for the immediately diagnosed diabetes. Now, normally I have seen that we have this habit of, giving level 1 drugs, prescribing level 1 drugs, which usually the primary care physician does. Now, as a diabetologist, would you refer the person to continue on those drugs while diabetes is such a dynamic theme and newer drugs are coming? So what the government is doing, which I believe is they are, continuing to give the age-old drugs to the first level. So do you see that very encouraging, or again, are we adding to our problems in future?
Actually, that was what I aim. That we are thinking about PSC. Okay, government is providing 2 drugs. The most of the programs or guidelines are basically concentrated on 2 drugs. Once you have done with the 2 drugs, you refer. But what the second person is going to do? Obviously, we'll be adding drugs. If something is available at PSC, same thing is available at CSC, same as district hospital. If his prescribing patient is to take from outside. So I think there should be a flexibility. Means we should use what is available at a cheaper. But once patient is not controlled on a cheaper medication, obviously we're going to ahead with the 3rd or 4th line drug. Right? So the program should have that facility in place. If that has to be done, what has to be done? And even in the newer drugs, like out of 6 drugs, now 2 more drugs are basically cheaper. SGLT2 inhibitors, DPP4 inhibitors, these are very good drugs. Initially, the price was around 40 or 50. Now it has become less than 10 rupees. So the most of the patients can still afford. So again, what we tried in that CDSS system is that give all sort of flexibility of drugs so that the prescription is generated and then patient can see what is available in house and what need to be purchased from out house. Hierarchy obviously has to be that what is available in house. But we should be flexible because not all patients are poor. No? We should not think that all patients are poor. 100% patients are poor. Even if they are poor, if 3rd drug is needed, 4th drug is needed, then where is a way out? I think the mind should be dynamic. Even with when we frame the guidelines, that if we start even program, we start with the metformin. We give that if patient is requiring 2nd drug, you give sulfonylurea because it's available. So taking cost into account, we serially added 1, 2, 3, 4, 5, 6. Right? Patient is obviously going to move ahead. So we should not restrict our thoughts to that thing.
Sir, during pregnancy, at least one visit done by OG specialist by the patient. So in diabetes also, I think that at least once a endocrinologist or a diabetologist should see a patient from.
I'm not sure how practical it is. If I have to make it simplify, like diabetes patient who requires treatment has to be connected to the healthcare system, right? Then there's a second element of promotion. If, for example, we are in a situation where 50% are pre-diabetes, another 20-30% who are normoglycemic will be obese. So basically health promotion is required for practically each and every person. So again, grassroots level thing has to be strengthened. But obviously, for example, we talk about video sessions. No? For example, we are preparing from keeping that into mind that we are testing it in evidence-based manner. So we are making video sessions for the women or for the men. And once they are successful, we can easily host at the national server. So which can be like just played at the with the help of audio visual at the PSC level by the Asha. Okay, there is a one camp where videos are getting played, people see, and just after that 20 minutes, 40 minutes, there could be interaction and doubts which can be cleared by the local persons. So no one has to prepare additional material. No one is burdened to take sessions at the afternoon. For example, if we are taking session 20, most of the people feel sleepy. Right? So this is a natural thing. So to overcome, we realized that if we are taking session at 3, most of the people will go to sleep. So the person who is taking lecture is also means that part. So from that angle, we realize this reality. So we are make like 60-minute 4 sessions, physical activity, diet. We are also making means video for physiotherapy, different sort of what sort of exercise regimens are required. So that can be hosted and can be played, downloaded at the ground level, played in just 20-40 minutes. That what we are interacting is more meaningful than when we are dictating things. So this is one thing which need to be done.
Thank you, sir.
I think fasting, if we talk about in a reality, fasting plasma glucose, if we can get, that is best. Because the patient can't spend 2 or 3 hours because most of the villagers will be working, right? So we're expecting someone to stay at the 3 hours for the health system level is difficult. A1C is costly. So in near future, all PSCs or CSC maybe not be equipped with the costlier things. Even if we have a fasting, it can give you well idea. Like if we say that less than 130 is controlled and you see a patient of fasting of 180, so you can just get a good idea. I think if one test I have to promote, that is a fasting plasma glucose. And obviously if you need a patient who is like having 2 drugs, 3 drugs, like once means if it is only metformin, fasting is enough. If there is sulfonylurea or something more drugs or complicated drug regimen, then fasting and PP is good enough. Yeah, pregnant because after 20 weeks it's predominantly the means post glucose challenge test which is derived. But even in Indian setting, 60 to 70% of the women can be picked by the fasting alone. So fasting is very good test which can be like easily accomplished. Reality.
Thank you, sir. Thank you.
Sir, with your presentation, the first case scenario is a type 1 diabetic. So then 26 years male, he came with some other problem to the facility. Maybe opportunistic screening is done there. And he's got that fasting done. And fasting it showed about 300 odd. So is there, can we say that with this one fasting blood sugar for 26 years old that he is diabetic? Can we rule out that?
Yeah, basically if patient is symptomatic, you can just, because any glucose value above 200 in a symptomatic patient is diagnostic of diabetes. But since you're giving a label to a patient, negative label, what we say, no? Means suddenly I say you have a diabetes,
yes.
Right? The patient will just crash. So it is better to confirm with another test, right, before giving a label. But
Yeah,
if there is some sort of urgency, for example, if you do fasting 300 young patient is having osmotic symptoms, then waiting for a second test may not be good enough.
Okay.
Right. But in general, there is a practice that whenever you give a negative label to anyone before saying you are having a disease, better to be sure on a. So every disease, most of the diseases require 2 tests to be sure. Yeah. In diabetes, it is also. So.
Yeah, my query was that only because that case scenario was missing that part. It was directly into fasting blood sugars, and then I was diagnosed as type 1 diabetic. So I
deliberately not included to means from a patient perspective. I just wanted to give that these are the sort of patients which come. We have to think that how these patients can be retained and how this patient can be educated at the grassroots level.
Yeah.
So without going minutely into a particular patient, that was a concept behind putting these 2 patients.
Okay. Thank you.
I want to thank you for your presentation, and I wanted to ask you the 2 case scenarios you gave. Both the patients are from Bihar going back home. So how practically, how do you ensure fertility of care at this stage?
I think that's the reason because we have apprehension. Like even after 7 years sitting in names, whenever I see such patient, we just stop and think for 2 minutes, like how we are going to cater these patients. But again, I don't think so. There is some solution because, for example, if someone is coming from Kolkata, right, there are people even come from Kolkata. There are like good endocrinologists there. So if I know someone, I can connect with the endocrinologist. But that is a means thing. It's I say bi-directional learning. because more we interact with the nodal officers at the PSC level, more we understand the healthcare system, and more we strengthen the healthcare system, we can refer it back. But at present, I don't have any solution for such patient, how they are going to be dealt with.
Track system, if it's adopted by the government and enforced pan-India, that will help in referring across.
Yeah, so that is a system, because what it happens, it avoids duplication of work. For example, if ANM or ASHA is entering at the grassroots level, what information has gone is available at till district level. So it's only means people can add incremental things. Something has been entered by one person. If something is missing, added by the another PSC person, another DSC. All information is going to in this ERF and is available at all system levels. So it avoids the duplicacy of work. Right. So it's basically after intense research by Dr. Nikhil Tandon for the last 10 to 15 years at health system levels, he has realized and made this sort of program which decreases the burden of a doctor, involves more of a paramedical staff. That is why that nursing persons are very important in this game, right? And decreases the duplicacy of work. Same patient, same details, 5 persons are taking. I think that need to be avoided. And more focus has to be given effective management. So that is a purpose for that evidence-based, flexible, dynamic clinical decision support system, utilizing the paramedical staff, and doctor can just concentrate efficiently on more of an interaction.
We will be moving to next session.
Yeah. Thank you so much. It's fantastic to have interaction with all.
Thank you, sir. Next session is by Dr. Ashutosh Agarwal. Sir is Professor and Head of Department of Pulmonary Medicine at PGI Chandigarh. Sir's major research interests include epidemiology of chronic respiratory disease, pulmonary function testing, and health-related quality of life. Sir has spearheaded the development of spirometry guideline in India. Over to you, sir.
Good afternoon, everybody. And I must apologize that I am there not in person due to some clashing local commitments. But today, just let me share my screen first.
Sir, you have to unmute.
Yeah, I hope my slides are visible. Just
it is visible.
I think there is some issue. I'll do it again. Okay, so today I'll be briefly discussing how we can strengthen the delivery of chronic respiratory disease care through our national non-communicable disease program. In contrast to some of the other non-communicable diseases that are being discussed today, we do not have a formal CRD vertical in the National Disease Control Non-Communicable Disease Program as of now. Although there is some move to incorporate chronic respiratory diseases into the NCD basket for programmatic care, delivery of care. So chronic respiratory diseases include chronic obstructive pulmonary disease, asthma, interstitial lung diseases, occupational lung disorders, and several others. Among these, by default, only COPD and asthma are included for programmatic purposes because these are of the greatest public health significance. Unfortunately, we still do not know the true epidemiological burden of either of these disorders because there is no standard case definition for both of them. It is mostly dependent on a physician diagnosis, which is supplemented by clinical details and some physiological workup. Moreover, there is also considerable underreporting, especially in the developing world, because especially asthma in general is associated with some kind of stigma, and therefore there is a lot of underreporting. So as per the global burden of disease estimates for 2019, asthma remains the most prevalent chronic respiratory disease, estimated to be about 262 million globally. And this prevalence is about 1.25 times the number of cases that are expected to be present globally, around 212 million. However, the mortality from COPD is 7 times more common than from asthma. So even though the number of COPD patients might be less than those of asthma, they are associated with a higher mortality, a much higher mortality in fact. And not only mortality, there is also a lot of morbidity. Globally, asthma ranks 34th and COPD 6th amongst the various causes that contributes to daily rates as per the GBD estimates. And therefore, really no government can afford to ignore the rising burden of chronic respiratory diseases, more so in resource-limited environments. So this is just a figure that tells you the relative morbidity associated with some of the chronic of the non-communicable diseases. And you can see that COPD and asthma are quite significant in the NCD basket, even though their prevalence might be less than some of the other important non-communicable diseases. Their contribution to morbidity is quite high. And a similar figure is there for India. And you can see that the COPD asthma portion is disproportionately larger than what we see in the global estimates. So therefore, there is a lot of burden because of both COPD and asthma in the country as well as globally, and therefore we need to take strong measures to control these diseases, to treat them properly through programmatic means. So the global NCD action plan was, everybody knows, was adopted in 2013, and it aimed at a 25% relative reduction in overall mortality from NCDs by 2025, and these NCDs also included CRDs. So sometimes this is also referred to as the 25 by 25 rule. And in addition, the action plan also pointed towards a 30% relative reduction in current tobacco use. Tobacco use, all of us know, is a major risk factor for COPD. However, this action plan fell short of suggesting a specific CRD agenda. And it also failed to prioritize reduction in ambient and household air pollution that, at least in the developing world, is supposed to drive the asthma and COPD burden in these countries. So there is clearly, therefore, a need that individual governments should address some of these lacuna depending on the local needs. For instance, India has added a target of 50% relative reduction in household solid fuels for cooking by 2025. And this is an additional framework element for NCD prevention and control, at least in this part of the world. And there is also an urgent need to include the chronic respiratory diseases to the priority list of non-communicable diseases that are to be managed through the existing NCD control program. So as I stated earlier, so far the chronic respiratory diseases do not figure in this priority list, and therefore their care is not delivered programmatically in most of the countries. So if you really want to integrate this care into a NCD program, then there could be two approaches to doing this. One could be the vertical approach, which means you develop a standalone operational plan to manage both these disorders, asthma and COPD, and you develop this program from scratch. So this is a separate vertical in the NCD program. And the other approach is a horizontal approach, which means that you use existing NCD program resources to deliver this disease control as an integral part of other NCD programmatic activities. So obviously the horizontal approach seems much more cost effective, both from implementation as well as managerial perspectives, because then you can really pool in resources from some of the other programs, and it also avoids a lot of duplication of activities. So therefore, the horizontal integration seems to be the preferred mechanism. To begin, we will need to develop some operational guidelines both for prevention, diagnosis, and management of the CRDs at primary and secondary levels of healthcare. And this for programmatic implementation is probably one of the most important prerequisites before such a program can be initiated. Now, all of us understand that there are a lot of evidence-based expert recommendations which are individual for both asthma and COPD, like the GINA guidelines for asthma or the GOLD guidelines for COPD. And these guidelines are evidence-based and get periodically updated, sometimes even every year. So there is no dearth of expert opinion on how to diagnose and manage and prevent these disorders. However, these guidelines do not specifically apply to the primary healthcare level, where resources are rather limited for both diagnosis and treatment. And these are more of evidence-based guidelines rather than operational guidelines. So to counter this, we sometime back proposed an algorithm for diagnosis and management of COPD at different levels of healthcare. This is quite an old initiative which was promoted by the WHO, in which we tried to build an algorithm at what all could be done at the primary care, when patients needed to be referred to the secondary care level, and when to the tertiary care level, depending on the facilities that were available and whether or not the patients were responding to the treatment and investigations were available or not at each of these levels of healthcare. As you can see from this flow chart, our basic aim was that wherever the patient is diagnosed or treated, he should ultimately come back for follow-up at the primary healthcare level, and most of the investigation and treatment, both initiation and maintenance, should be offered at the primary healthcare level, because that is the closest for the patient and most convenient for him for a long-term management. So these kind of operational guidelines need to be developed, and they need to focus on some of the locally important risk factors. They also need to account for what healthcare resources are available, both in terms of infrastructure and healthcare personnel. And in addition, although the guidelines are separate for asthma and COPD, any CRD program that we roll out as a programmatic activity will need to deal both with COPD and asthma together rather than separately, because you cannot have two separate verticals within the same program. So that brings into focus an important clinical aspect. So we really need to begin evaluating patients with respiratory symptoms and or risk factors for either of these diseases, not for individual diseases. And once we have shortlisted some of these patients, then we during the clinical workup, we need to distinguish between asthma and COPD, as well as rule either of these diseases out if it is not present, through very simple clinical and laboratory parameters. Nothing fancy, nothing that requires referral of the patient to really higher levels of healthcare. Also, during the course of management and evaluation, we need to assess disease severity and control, again using locally available resources. We need to prescribe medicines and other non-pharmacological interventions also locally, depending on the resources that are available. And we need to monitor these patients again using simple tools, something that can be easily achieved at the primary healthcare level. At this level, we also need to factor in the community aspect, because community empowerment and engagement is quite necessary to facilitate prevention, early diagnosis, and care. So note that as for all other non-communicable diseases, prevention is one of the more important pillars of programmatic management, especially at the primary healthcare level. And in the community, we need to develop processes and tools that the community can easily access, and tools that are acceptable to the community. So we cannot just blindly follow what the international guidelines which are tailored more towards the Western populations state. We have to develop our own tools that are much more simpler and easily carried out at our own primary healthcare level. And at the community level, we also need to promote health education, risk reduction, because just diagnosis and management is not everything. And we need to build in referral mechanisms when the patient will go from primary to secondary, when from secondary to tertiary, and how he will be referred back for ultimate management and monitoring at the primary healthcare level. This brings us into another important aspect, which is the finances. So we all understand that financial constraints are an important consideration, and therefore there is some difficulty in rolling out these programs to their fullest potential. But we must also understand that there are economic and social costs associated with uncontrolled disease. For instance, children will not go to school if their asthma is poorly controlled, and patients with COPD will not be able to go to their work and offices if their disease is poorly controlled. And this is very important, especially in the economically productive age group. And this aspect cannot also be neglected. So when the health managers say that there are not enough finances, we have to stress upon them that there are also economic and social costs associated with not managing the disease. And in the end, these are likely to balance out. So ultimately, the finances will not be too prohibitive. The second aspect is that because of these financial constraints, as of now, only oral bronchodilators are freely available through the public health system because they are quite cheap. But inhaled drugs generally are not available, although they are available in some states or in some primary and secondary healthcare centers. But it is not a universal phenomenon. Again, this is something that we need to change because all guidelines nowadays lay stress on inhaled drug therapy rather than oral drug therapy. And we must not consider the poor and underdeveloped nations as second-class citizens. They are entitled to the same level of care and the same standard of care that is expected in resource enriched settings. Again, to implement all this, we need a strong political commitment, which sometimes is lacking because, like for instance, we proposed the integration of CRD activities into the NCD program maybe about 3-4 years back, and AIMS and other institutes were important in proposing these guidelines to the ministry, and WHO was also involved. But so far, really nothing has come up in the field. I understand that some pilot projects have been taken up, and there is some movement in this direction, but it is quite slow. So we need a strong political commitment to enhance this delivery of CRD care. And also, we had proposed in those guidelines that we should not dilute the evidence-based guidelines that are currently exist. So patients should be offered the same level of care, including all the inhaled medications. And it is up to the health administrators not to dilute the existing guidelines when the program gets implemented. This obviously will entail upgradation of both diagnostic and therapeutic services, and this is going to cost money. But I think it is going to be money that is well spent. And we also laid some stress on capacity building because we understand that with horizontal integration, some of the existing resources will be utilized. For instance, if we say that patients require pulmonary function testing, then who will do this pulmonary function testing? So maybe the ECG technician at the local healthcare center can be trained to also perform the lung function testing, because he's a relatively more technical person who has the knowledge of handling machines and interpreting reports. So this kind of capacity building also needs to be done as an administrative exercise. So generally, what is available to us as of now? So there are WHO pen packages available for both asthma and COPD, and these are primarily focused towards the primary healthcare level. These are slightly outdated as of now because they still do not impart the full package of clinical care that is now globally recommended. In addition, there are some country-specific guidelines. For instance, there are evidence-based guidelines, India-specific, for management of both COPD and asthma. These are at the behest of our national chest societies. And these are also evidence-based, but these are tailored slightly to for the situation that exists in India. So some of these guidelines could be a starting point for development of national plans and operational guidelines. Sometime back, the World NCD Federation also came out with guidelines on non-communicable diseases. And these laid stress not just on diagnosis and management, but also on prevention and other aspects. And these again could be provide a framework for promoting the operational packages. So this is one kind of package that we proposed in these guidelines, which could be implemented at even the primary health level. And this begins with assessing patients who present with breathlessness, wheezing, chest tightness, cough and or sputum production. So general respiratory symptoms which could be seen in patients with asthma and COPD. We try to horizontally integrate it with existing programs, for instance, the National Tuberculosis Elimination Program, so that if symptoms were suggested, then patients will end up with sputum testing to pick up any tuberculosis that we might have missed. And only if negative will they go on for further workup, and we will do a detailed examination, take detailed history on risk factors and triggers and so on. And finally, try and fit them into a basket of probable chronic respiratory disease, either asthma or COPD, or rule it out. We might end up saying that these features do not suggest either of the disease, in which case the patients will be evaluated and treated for whatever seems to be the more likely diagnosis. We also laid stress on spirometry as the lung function test for establishing the diagnosis, for assessing asthma control and severity and so on. And this is also something that is currently not available at most places. Sometimes even some of the tertiary centers and even medical colleges do not perform or do not have a reliable spirometer in their armamentarium. So this is again something extra that we have tried to propose. And we suggested that after we have given these patients a label of probable asthma and COPD and tried to distinguish whether it is likely to be asthma or likely to be COPD, we should initiate empiric therapy at the primary healthcare level itself and schedule follow-up visits and try and educate the patient on the disease and also on treatment. So everything can mostly be done at the primary healthcare level. And this is how we could, on clinical grounds alone, try and distinguish between asthma and COPD depending on the age of onset, what is the disease course, what are the risk factors, are there any triggers or family history, what are the general symptoms, what are your physical examination findings, and whether or not the patient has any complications related to COPD. So by simple clinical tools, we can, in most instances, put the patients either as having probably asthma or probably COPD, and then initiate the further management accordingly. For COPD, we also would want to assess severity, and this again we propose that could be done with locally available tools. MMRC is the Modified Medical Research Council dyspnea scale. Just ask the patient at what level of activity he or she feels breathless. We count the number of exacerbations that he has had in the last 1 year that mandated either change in treatment or required hospitalization. Whether or not the patient has any complications. These complications include respiratory failure, right heart failure, or secondary polycythemia. And this information could be supplemented by spirometry if this data is available, and we can compartmentalize these patients into mild, moderate, or severe. This is slightly different from the international guidelines, but we proposed it because we thought it was more practical in the Indian scenario, especially at the primary healthcare levels for the physicians there to be able to take quick treatment decisions and assess the severity of disease. So that brings me to an important point on why spirometry is necessary. It is extremely important, especially for COPD patients, because it establishes the O, or the obstructive component in COPD. This helps us to avoid missing early disease, as we all know that clinical features alone have poor sensitivity and specificity for diagnosis. This helps us to stage disease severity, and this may also be used as an incentive for asking patients to quit smoking. You can tell them that their lung function is reduced by, to say, less than 50%, and this could be an incentive for them to quit smoking. Despite recommendations by all major guidelines, physicians across the world still continue to diagnose COPD on clinical criteria rather than use spirometry as an objective tool, and India is no exception. Here, of course, we are worse off because spirometry is not routinely available in the primary and secondary levels of healthcare. So for COPD management, again, we prescribed a very simple guideline. I will not go into the details of what specific treatment has been proposed, because obviously that can change as the guidelines evolve. The only things I want to highlight is that we have tried to keep the guidelines simple. We have omitted a lot of the options that are available in the international guidelines. Instead, we have tried to focus on specific drugs which can be made available in the healthcare system. And there are really no options. So, so if the patient has mild COPD, then this is what he gets. Because if we allow too many options and some of them are not available, then they will create confusion in the minds of the physicians who are manning the primary health centers. And then there is a gradation. So there are separate drugs for mild, moderate, and severe disease. And there are also there is also scope for adding additional drugs if the patient is not controlled adequately at any particular level of drugs. So this also imparts some bit of flexibility in the program, and this kind of simple algorithm can help the patient, the physicians decide on treatment at the primary healthcare level. And we also propose that when the patients really require to be referred to the next level of healthcare, so that is if there is an inadequate response, there are some new complications, or the physician suspects that there is an alternative diagnosis. Similarly, for asthma, we think that we should assess the level of asthma control while the patient is on treatment. And again, this is purely on history. You ask for symptoms, how many times the patient has required SOS medications, are the activities limited, and you supplement it with the information from lung function testing if this information is available. So very simple, you can categorize them into inadequately controlled or adequately controlled. Inadequately controlled patients require hiking above therapy. Adequately controlled patients can be continued on the same therapy, or you can try reducing the therapy also. So again, this is a simple flowchart of how we propose asthma should be managed. Again, do not go into the specifics, but just look at based on the degree of symptoms, how symptomatic the patient is, you could start different sets of drugs at each level. So this again is a simplified approach so that the physicians are not confused. And again, depending on the level of control, you can either move downwards into adding more drugs or increasing the doses. And if the patient shows good control, then you can even try reducing these drugs to a level that is below his current use. So again, everything can be really achieved at the primary healthcare levels if the drugs are made available. And again, we have tried to suggest the drugs which can be used together both for asthma and for COPD, so that drug procurement and stocking and all these things are easier to implement. So these are the medication lists that we suggest, that we obviously will need to rely on the inhaled drugs and not on the oral drugs. So budesonide and is mostly for asthma. The other drugs can be used both for COPD as well as for asthma. So we also propose that there should be some nebulizing solution available at primary and secondary health levels, so that patients who come with exacerbation can be stabilized before they are referred to the next level. And similarly, this oral aminophylline for stepping up of the treatment, and oral prednisolone for managing the exacerbations of asthma and COPD. So a very small drug list, something which can be easily made available from the program perspective. For the infrastructure, again, much of this infrastructure currently does not exist. So we proposed at what level of healthcare, what all infrastructure should be available, what should be essential, and what should be desirable. Desirable is more of a long-term goal. So, but first we have to make sure that the essentials are available. And again, these are simple bits of equipment, most of them, except for spirometry. So spirometry we currently propose should be available at slightly higher levels of healthcare, but it could be made available at the lowest level through simple means. For instance, through mobile vans. The previous speaker also mentioned something about how the diagnostic facilities could be delivered through mobile vans. So you could have, say, a spirometer at the district hospital, and a mobile van can move into different locations, maybe once a week or once a fortnight, where patients could be collected by the local healthcare staff. So you might say that, okay, today we have 3 patients in one village who need to be tested. So that van will come in the morning, test the patients, and then go back. So through some such local mechanisms, you could ensure that the delivery of services is available right till the grassroots level. So you can also link this with other health programs. One example I already gave you, that how you can link it with the tuberculosis elimination program by doing a sputum smear examination in patients who are suspected to have tuberculosis. Then smoking cessation program is already functional. So this is another program that can be easily linked to the CRD program. And this linkage is important because you can share infrastructure and reporting mechanisms. You can share technical and paramedical staff that is already available for health programs. For instance, I mentioned that the ECG technician that is available could be additionally trained to handle spirometry also. And then the health promotion activities by healthcare workers can also be taken together. So this health promotion should be also an important thrust area. The preventive activities we can implement at the grassroots level. Quitting tobacco is obviously very, very high on the priority list, and this has to be done especially for all COPD patients. And we must ask family members who smoke also to quit and at least avoid smoking in presence of the patient, children, and pregnant women. For asthma, there needs to be some health education so that patients can avoid trigger factors if they are known, and they should avoid dusty and smoke-filled areas. So, so some of these points are part of the health education, which is extremely important. Another important initiative is that we should move away from solid fuels for cooking, etc., because indoor air pollution is an important risk factor for COPD as well as for asthma exacerbations. And obviously, the government has taken some steps in this direction. The Ujjwala scheme, for instance, is trying to promote LPG access right at the periphery. So, so a lot of these preventive activities should be part of the program.
Yeah, if we are really running late, if you can.
Yeah, this is the last slide.
Okay, yeah, thank you.
So in summary, I would just need to emphasize that we must transform current evidence-based guidelines to simple operational recommendations that are well suited to primary and secondary levels of healthcare without diluting their scientific content. We need to include both asthma and COPD into a common protocol for diagnosis, management, and prevention. we need to horizontally integrate the CRD program with the existing NCD as well as other programmatic activities. And we will need to upgrade our resources within the existing frameworks for this program to be successful. So thank you for your attention, and I'll be happy to take a few questions.
Due to tight schedule, we are already running 30 minutes behind. So I think question and answer session can be left, and we can move to next session, if it is okay with you, sir.
Yeah, it's fine with me.
Thank you, sir. Next session is by Dr. R. Kesavan. Sir is technical focal point for non-communicable diseases at WHO CRO office, and sir is also fellow of Royal Society for Public Health, UK. Sir, you can.
Yeah. So good afternoon, everybody. Can you all hear me?
Yes, sir, you are audible.
Right. Thank you so much. And I think if you can share my slides. You have my latest version of the slides. Okay. Meanwhile, while he's sharing, I would like to assure you all that it is not going to be a very serious lecture, because I know that you are all so tired after the heavy day, and this is the time I can see somebody already sleeping. So I will make you to wake up, because this is nothing serious. This is going to be just something common sense we are going to talk. So are you able to share it?
So just a minute.
Yeah. Okay, thank you so much. So actually, I was given a topic which was, I was sometimes thinking it's funny. So addressing comorbidities and complications of NCDs, non-communicable diseases. You know, when you take the word comorbidity and complication, and these are all just terminologies, and sometimes it all means almost the same conditions, and it's sometimes comorbidity we call it, sometimes we call it multimorbidity, and sometimes we call it the complications of the non-communicable diseases. But also this word became very famous when during the COVID era, because you know that during the COVID time, everybody was saying that people with comorbidity needs a priority for vaccination. Most of the people who died with COVID had comorbidity. So this comorbidity became a very significant term. So the burden of NCD, actually 68% of the global mortality, and it is going to be 74% in 31. And also, so you know that it is going to be a big burden, and for countries like us, it's going to be a double burden with communicable and non-communicable diseases. And what are the major non-communicable diseases we are actually looking at? Actually, cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases. These are the four diseases, not to mention that I wouldn't say that other diseases are less important, like neurology, mental health. They are also important, but these diseases has the highest burden at the moment. And tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol are the four major risk factors we can encounter all the time. So here, when you see the meaning of comorbidity, the presence of one or more additional disease. So, I mean, what is comorbidity? You may be thinking that a person who is having diabetes is also having hypertension, And so here, if you consider diabetes as the major disease, the hypertension is a comorbidity. And if you consider hypertension as a major disease, diabetes is a comorbidity. So it could be one thing. Maybe they have also hypertension, diabetes, then also fatty liver, or the person also may be having epilepsy. So there can be multiple diseases. So if you think that terminology could be comorbidity or multimorbidity, but usually we use multimorbidity when there are a lot of diseases together or lot of conditions together. And comorbidities are usually the former slide, please. The comorbidities are usually long-term and chronic, and they may or may not interact with each other, because sometimes you see that a person who is having high blood sugar eventually could end up in also fatty liver. But a person having hypertension may not interfere with the blood sugar. So comorbidities can coexist with interfering with each other or not. Next slide, please. So the comorbidity simply means more than one illness and disease occurring in one person at the same time. And multimorbidity means usually two or more illness. So this is not a very hard and fast definition. Don't worry about it. Usually, if we say multimorbidity is more illness, more diseases. Next slide, please. Yeah. So what is the complication and the what is the difference between complication and comorbidity? Okay, you take a patient with severe hypothyroidism, and the patient is not diagnosed early, but patient goes on like that, and one day what happens is, because of the hypothyroidism, patient has got hyperlipidemia, severe hyperlipidemia, patient has got fatty liver, then the patient, so this fatty liver, is it going to be a complication of hypothyroidism or comorbidity of hypothyroidism at the time we are really diagnosing? So when we diagnose, we may think that it is a comorbidity. This patient is having hypothyroidism as well as fatty liver, as well as hyperlipidemia, but it is actually, you will know that it is not really, it could be a comorbidity. It appears today, but it is a complication of the initial hypothyroidism. So you can see that the complication is a side effect of a medical problem that may develop during the disease after a procedure treatment, or it may be caused by the disease procedure and treatment and not to be related to them at all. Also, even if you are doing a surgery and by mistake you are severing the one important nerve, right? Then it results in the inactivity of the limb. So it is again a complication. So complication could be anything, could be due to anything. Some side effects could cause complications. And comorbidity is a separate illness or disease a person may be having along with the primary health concern. So that is the difference, but there can be a lot of overlapping of comorbidity and complications. Next slide, please. So the factors leading to comorbidity, I have to be very fast, I am sorry. So the social determinants, that is poverty, social deprivation, climate change, pollution, lifestyle. You may be wondering, because this is, we are touching the public health, and you know that you may think that what is poverty to do with this comorbidity and NCDs, poverty, social deprivation. So you can see that it may be, you take a condition of extreme anemia, that is iron deficiency anemia, and chronic, when it's chronic, it may lead to cardiac failure, you all know. So patient presenting with cardiac failure, that is a NCD condition, but it's caused by the anemia, it's caused by the poverty. And the patient also may be having a comorbidity of protein energy malnutrition. So you can see, or you see that a person in poverty always live in an area which is air polluted. He has no way to escape. and that is his lifestyle. And the climate change has caused more pollution in the air, especially in Delhi. And so those people develop more pulmonary airway obstetric diseases. They develop more of bronchial asthma. So, so again, you can see that these NCDs and all these comorbidities, if they have, has something to do with the social determinants and unattended risk factors. So, if somebody is having a diabetes and he is smoking, and he is then he argues that his blood sugar and smoking doesn't have any relationship, but what happens is he gets the lung cancer eventually, or he gets hypertension. So because he did not attend the risk factors, he had comorbidity. So this is happening most of the time in many of these of people. And failure for early detection, sometimes you don't detect early. So what happens, what I was telling, like the example of hypothyroidism, many persons actually end up in cardiac failure, left ventricular failure, and maybe even worse conditions, and they find it that the patient had untreated or undetected hypertension for more than 10 years or 15 years. This has been a very common case. So that's why we say that we need the people-centered NCD care with early detection and early management. And also failure of early detection and poorly managed disease conditions. Okay, you detect early, but the patient is not taking the medications, right? Patient is not able to take the medications. There are two conditions. Medications are available, but patients cannot access it because patient cannot afford it. Or maybe patient, if a patient is going daily to work and you are providing the medication on Tuesdays, 10 o'clock in the morning, he cannot take a leave from work and come to. So he prefers to go to the work and not giving importance to the medication. Then what happens? He thinks that I have only 20 glycomet tablets. I need to maintain it for maybe 500 gram he is taking a day. He makes it 250 gram a day, and so that he can take for double the time, so that he need not waste his time going to the waste is actually what his interpretation, going to the clinic. So these are all our social factors which makes him not to access the medication. So what happens? The diabetic gets worsened. When the diabetic gets worsened, he gets all these other complications like renal complication, eye complication, and also everything. And then even it can lead to cardiovascular issues later on, and a lot of comorbidities. So the poorly disease managed conditions are not as we think. Always the mistake of the doctors, always the wrong doses. It could be always, it is not always the expired medications, not always these things, but there are other hidden things which we should be thinking of. Next slide, please. Yeah, and the factors leading to or multimorbidity could be genetics. You all know, sometimes why we call it essential hypertension. We don't know the reason. And there can be juvenile diabetes, where you cannot. So a lot of genetic factors are there. Then as age increases, definitely we will get more and more burden of diseases, NCDs. So a person of 30 years, more than a person of 40 will have more, 50 will have even more, and maybe having that 2 or 3. So comorbidities increase with age, and also it depends on the gender. For example, this cardiovascular disorders has been found to be less prevalent in women, but psychogeriatric diseases are more prevalent in women. So these are some findings. So I mean, because there is a gender difference in NCDs and comorbidities. Next slide, please. So driven by the similar risk factors together with demographic changes, including rapid urbanization, aging population, these diseases are closely interconnected. You know that many of these NCDs and the comorbidities have the common risk factors and common conditions and common reasons of rapid urbanization and all these things. And so they are very much connected. And some diseases predispose individuals to develop others. That's I have already mentioned. So the risk factor, the diabetes, which is a risk factor for CVD, stroke, osteoporosis, kidney failure, and depression. So you will be wondering, a person with diabetes, there is a huge percentage of persons with diabetes also diagnosed with depression, or maybe not diagnosed but having depression. So these are all interconnected, and is all these the morbidities are caused by each other. And people often have both physical and mental health issues simultaneously, but sometimes they actually, because of the physical issues, their mental health issues are not very much addressed, or maybe because of their mental health manifestations, their physical issues are not really looked after. And multimorbidity had the highest risk of active patient safety incidents and precursors. Next slide, please. So people with multiple conditions may have higher overall vulnerability to disease and less resistance to acute health threats. You all know that. You all know that COVID has shown us very well that the importance of the NCD management has been shown by the COVID. So all these people with multiple conditions, comorbidities, were more prone to COVID. The mortality was higher among them. So that showed us that the very need to treat NCDs and keep the NCDs under control. And multimorbidity leads to an increased likelihood of referrals between different providers of healthcare. You know why I am telling this? I mean, you go with some diabetes, and then they look into the eye, they refer to your eye ophthalmologist, then they'll refer you to a retinologist, ophthalmologist will look into that and refer to a retinologist. The retinologist will look into that, and maybe now it has not come, it will be in eye anterior chamberologist, posterior chamberologist, and somebody will refer to a cardiologist, and cardiologist will refer, in future they say there will be left atrium specialist, right atrium specialist. So there can be so many multi-specialities, and so the patient will be really having half of the life going to subspecialties. So these referrals, multi-speciality is good, but also multi-speciality can cause real issues in so that we will come later why we need more generalist than multi-specialities. And so this multimorbidity has a lot of referrals, which I have mentioned. It's a real trouble, and this can increase the cost and lead to more fragmental care, thus compromising patient safety through poor integration of care, poor communication and coordination. You know that when the patient is thrown between many specialities, because of the communication, because of the errors, patient is more vulnerable to be, he will be under real trouble. Next slide, please. So also when you have many diseases, morbidity, so when you have a lot of comorbidity, polypharmacy may lead to poor medication adherence and adverse drug events. So you are given metformin, you are given Rosafin, you are given we are given about 5-6 tablets, and the different time intervals, you may forget. You can't remember each and everything, which is after meals, which is before meals, which tablets to be taken, which tablets is going to be finished, which tablets you are going to get again. So it's a complex management regime, and also more frequent complex interaction with healthcare services lead to greater susceptibility to failure of care delivery. So, then it is then when you go back to the doctor and you say you have diarrhea, then he is wondering which tablet have caused, or whether it is not the tablet, whether it is something you ate on the shop or something. So actually, when there are multiple morbidities and when there are multiple medications, then there are again very much complications. So these are the challenges we are looking at now. Next slide, please. increased need for clear communication. So there will be a need for clear communication and patient-centered care due to complex patient needs. So that is again going to be a challenge. How the need will be increased. So we will be in a position to make it. And there will be demand for self-management regime and competing priorities because of I mean, so many complications. I mean, the patient may be trained to self-management of many things, and more vulnerability to safety issues due to poor health, advanced age. So it will be poor health. So it will be older. The cognitive impairment will be there. Then there could be limited health literacy and comorbidity and of depression and anxiety also will be there, and you may not really notice it. It will be in a subclinical level. So these all make the patient more vulnerable to safety issues. Next slide, please. So when NCD comorbidities are associated with greater healthcare utilization and financial burden include most cases high level of out-of-pocket expenditure. So I'm coming to a macro level. So this will really cause greater healthcare utilization. So greater healthcare utilization, we may be using more manpower, more money, more medication, more everything. So that, and also for the people, when it will cause more out of pocket. You know what out of pocket? Out of pocket is how much you are spending out of your pocket for the healthcare. That's all. So in a lot of countries, the out of pocket expenditure is more than 50%. So 50% of the persons are spending money for their healthcare, their own money, and the out of pocket spent by the rich people, we are happy. That is income for the country. But when the percentage of out of pocket spent by the poor people, it matters a lot for us, and it matters more when it becomes a catastrophic expenditure and it causes impoverishment. So NCD comorbidities impose years of disability and compounded financial burden. So you know that comorbidities will have more years of this disability, then financial burden, and it will affect the families. And it's also affect the health system, because health system will have more burden, and also it will affect the economy of the country. So that shows how much you need to address these issues. And NCD comorbidities increases substantially with age in all countries, higher rates in urban than rural, and disproportionately affecting those who are the poorest. There is a 10 there, don't worry about it. Yes, it has just got in without permission. Okay, next slide, please. So health systems. So I just had a small example. Now we have HIV, AIDS, and tuberculosis, and in our countries with NCDs. So you may say that now effective treatment for HIV has come. So in one way, when you see the patients with HIV are living in the normal life, so they develop NCD as well, because these HIV conditions also sometimes may predispose to more NCD. So the NCD burden increases. So it's a double burden. Then some antiretroviral drugs may develop diabetes. It has been proven. So it becomes double burden. So sometimes we do good things, but it results us in more burden also to us. And diabetes is again a known factor for TB and reactivation of latent TB. So this is NCD causing communicable disease. It's again double burden. Next slide, please. Yeah. So the tackling the comorbidities, since the UN political declaration, so we have a political declaration that we will reduce the premature NCD mortality 25% reduction by 2025. So if we are going to do it, we need to move away from the single disease approach to health system, to integrate care packages and multiple chronic conditions. So we must have a holistic person-centered approach, and we must have an integrated healthcare approach than single disease approach. Next slide, please. So in order to address the NCD comorbidities, concerted efforts are needed not only for the treatment of chronic disease, but also produce population risk factors for NCD. And also we must have intersectoral health promotion, and also there must be this intersectoral health promotion should be done throughout the life course. Eliminated exposure to their shared risk factors. You know, there are a lot of risk factors are shared, and these sometimes we call it WHO best buy. When you are really imposing tax for cigarettes, or banning or stopping selling cigarettes, you benefit a lot. You benefit. Okay, I think there was a sound. Okay, now we'll go to the next slide, please.
Excuse me, sir. Sir, actually, there is very tight schedule and we are already running 45 minutes behind.
Yeah, yes, I know that, and I waited for 1 hour, and I need at least 20 minutes, basically, to have a lecture. I was given 30 minutes.
Yes,
but if you really want me to finish, I can finish. There's no problem, because I have another important international meeting at 4 o'clock. I will try to finish in 5 minutes. Okay, thank you. So we'll skip this slide. Go for the next slide, please. Next slide. Okay. NCD, we will go for the NCD complications. I'm sorry that I have to skip some interesting slides. So uncontrolled disease state despite optimum treatment. Sometimes you have you give the optimum treatment for the disease or diabetic, you give everything, but the sugar never gets controlled for several reasons. So what will happen when the sugar is not controlled? You have really, you get a lot of complications. Then complication due to immune response. Sometimes it could be immune responses. Actually, it is undesired immune response, autoimmune response. This can cause, and complication due to treatment. Treatment itself can cause complications. You know, the side effect of the drugs and unwanted side effects, sometimes dangerous side effects. Then complication due to the uncontrolled condition of the diseases. This I could able to, I mean, this is very interesting examples are there, like some person who got an autoimmune was treated with steroids, and the steroid it triggered his diabetes, and the diabetic when uncontrolled, so he had a retinopathy and he had a kidney transplant. So I mean, I can tell a lot of examples, but the time is my enemy now. Okay, then diabetes has retinopathy, neuropathy, and nephropathy. You all know hypertension can cause cardiomegaly, stroke, and renal failure. Bronchial asthma can lead to chronic obstructive airway disease. These are the complications. Next slide, please. Yeah. So sometimes non-compliance with the treatment regime, which I have already spoken, not taking the adequate dose, discontinuing the medication, not taking the quality medications could lead to complications of the disease itself because of the uncontrolled disease. Absence of recommended checkups, sometimes, you know why. There are many reasons which I have discussed. Any concurrent conditions and late development of complication due to treatment, sometimes, and continuous exposure to risk factors and unacceptable lifestyle. Next slide, please. So we'll just take one: non-compliance. So absence of the universal health coverage, the inadequate access and coverage of health services in terms of laboratory medications, then health-related literacy. We may have literacy, but health-related literacy may be inadequate, and there may be issues with attitudes and prioritization. What do you prioritize? That may be an issue that is based on the attitude and poverty. Next slide, please. So just a couple of slides more. Ensuring the UHC through the people-centered NCD care. This is the slogan we all say: universal health coverage. Then adequate health education and advocacy for health promotion. And to tackle the social determinants of health, then multi-sectoral action, and community participation as well as participation of the people living with NCD. So they are the most important people here at every level to make decisions. Next slide, please. Okay, I think the slides are over. I have to complete very fast. I'm so sorry. I had to be very, very fast. But I thought I will start at 3, but I could have not able to because it was so I had a meeting for until 3, and now in 10 minutes I have a meeting with Geneva. So meanwhile, any 1 or 2 quick questions?
There are no questions, sir.
Okay. So thank you so much. So thank you for listening and thank you for your patience.
Thank you, sir.
Bye.
Thank you, sir.
Okay, thank you.
Next presentation is by Dr. Puneet Mishra. Sir is professor in Center for Community Medicine, AIIMS, New Delhi. Sir is member of Technical Resource Group for Adolescent Health Division of Ministry of Health and Family Welfare, and member of ICMR Task Force on PCOS and GDM. And sir is member of Program Advisory Council, DST. Over to you.
So good evening to everyone. I know it's always difficult to be awake after post-lunch sessions, and I have also attended 2 of the sessions along with you. So I know many of you might be completely exhausted. So don't worry, I am not going to be very theoretical here. What I would do is that it's a completely different flavor, because most of the lectures I think which have been taken, they were on the modern medicine. So now complementary medicine, especially yoga and other therapies, they are coming up, but the issue is with there are many issues. The first issue is about the evidence, whether they are effective, they are not, do they have some scientific basis for treatment. So what during this lecture, since I have been allotted 25 minutes, I'll try to finish within allotted time, and might take few questions, because I'll go through some scientific evidences, and then based on my experience, because for last 4-5 years I started working in the field of yoga, and especially how to take yoga to the communities, and how to see the effect of yoga in different disease conditions, especially diabetes, mental stress, and conducted few of the RCTs. So at the end of this lecture, I would like to take questions from you, which I would try to answer based on my practical experience in the field, in the hospital setup. So I'll skip few of the slides because of the paucity of time. What is complementary and alternative medicine? Many times we use these 2 terms. So basically the approaches which are not part of modern system, and there are many approaches. So we use complementary when the traditional approach is integrated with modern system, it's complementary. When it replaces the modern system, then it's alternative. So usually we talk about the complementary, because we want to add complementary approaches to modern medicine, like yoga. If we are discussing, I'll discuss in detail about the one of the study which we conducted on yoga, and how it is complementary. And alternative, when people they say, no, I'm not going to take this treatment or that treatment, and totally going towards some other form of treatment, that is alternative. There are many approaches. It may be nutritional. You might have seen different people, they are advocating different kind of diets, different kind of supplements, then psychological practices like meditation, mindful breathing, etc., physical, different type of massage, then spinal manipulations, then psychological and physical, if we say acupuncture, yoga, and many more. I mean, in all part of world, wherever you go, they have some kind of traditional medicine, some kind of complementary alternative medicine, which is in different countries, especially in the Asian countries. Again, few examples. I'll not take much time here. I'll focus mainly on the yoga, on the aspect on which I work. So what is yoga? Many of you might be knowing about yoga. Many people, they confuse with the asanas. It's not the asanas, which is yoga. It's the complete practice, and it deals with the physical, mental, emotional, and spiritual health, actually. The word yoga is derived from Sanskrit root yuj, that means to join, to yoke, or to unite. Mainly, we use it for disease prevention, health promotion, and management of many lifestyle-related disorders. Why it is important in the context of non-communicable diseases? We know, most of the non-communicable diseases, they are lifestyle diseases. Most of the risk factor, they lie in the lifestyle, and that's why what you are witnessing in India. Because of the transition in dietary habits, transition in physical these habits, more and more number of people, they are getting non-communicable diseases. Especially if you see our population, they are getting diabetic, they are getting cardiovascular diseases and other NCDs at the younger age. So that is worrisome, and this practice that prevents and promotes many lifestyle disorders. So there are 8 limbs of yoga. This is lecture, 1 hour lecture in itself. So I'll not discuss in detail about all these limbs. So they are yam, niyam, asana. So asana is one part. Most of the people, when we talk about the yoga, they confuse it with the asanas, different asanas. The asanas is one part. It's not the total yoga. Then pranayam, pratyahar, dharana, dhyan, and samadhi. That is the last stage, samadhi. So how it is unique? Certain exercises, I'll skip this slide. So how does it help? How does it work? It works at the physical level, mental level, and the spiritual level, and basically helps in balance between material and spiritual world. Now moving towards few scientific evidences and the mechanism how yoga works and complementary medicine works. So basically, when we do yoga or meditation, it helps in the self-regulation, mood changes, psychophysiological changes, and it might help in improving the health. In many cases, it leads to reduction in drug use. That is for treatment, because the first thing is prevention, then promotion and treatment. So for many diseases, it may not be treating the disease in full. Like for diabetes, if you're doing yoga and you think, okay, this is gone. Maybe in few cases, if it is pre-diabetic, early stage, yes, it is. But with the regular practice of yoga, many of the cases of diabetes, they can be on the minimum dose of anti-diabetics and can maintain a healthy lifestyle with better control on HbA1c level. So if we talk about the role of complementary medicine in managing non-communicable disease, so it may be in all the aspects, whether we talk about the primordial prevention, we talk about the primary prevention, secondary prevention, rehabilitation, that is tertiary prevention, because public health professionals, especially community medicine people, they are very fond of talking at all the level of prevention. So that's why I put this slide here, that it works at all the levels. And certain examples are here, like for primordial prevention, mainly it reduces the stress. If stress is there, as you know, that stress leads to many non-communicable diseases. So at that level, it reduces the stress, also increases the coping ability. then primary prevention it reduces many inflammatory markers. If you see that has been proven, there's evidence that yoga practices, they actually reduce many inflammatory markers, which reduces the risk of diabetes, hypertension, and other cardiovascular diseases. Early diagnosis and treatment in like many communities, many different socioeconomic status, many people, those who do not have access to modern medicine or they do not go to the modern medicine, many of them, they go to these practitioners of alternative medicine, they get diagnosed early, so that you can say early diagnosis and treatment. And if somebody is having disease, then yes, it improves the disease condition. So the hypertension, there is enough evidence about control of hypertension through yoga, primordial, primary, as well as secondary. Then in cardiovascular disease, mainly through by reducing high blood pressure, stress, and sympathetic drive. These are the main ways through which it reduces the cardiovascular disease. And if those who are interested, they can search. I mean, a lot of studies has been done. I mean, from early days, there used to be Dr. Manchanda in AIIMS in cardiology department. He initiated many studies on meditation, yoga, and cardiovascular disease, and he has found that yes, and all those studies maybe 25, 30 years back they were done. Many studies has been done by Dr. Bijlani, who was professor of physiology at AIIMS. So evidence from India and abroad, it's available for cardiovascular disease. Mechanism mainly, it increases, heart rate variability, baroreflex sensitivity, then decreases the inflammatory cytokinins, and decreases heart rate, decreases blood pressure. It increases the insulin sensitivity, glucose tolerance. So these are the different mechanisms through which overall reduction or control of cardiovascular disease can be achieved with the yoga. Again, diabetes is a important disease which is on rise in India, especially in those who are younger people. If you see people in 30s and 40s, they develop diabetes type 2. While if you go to the West, most of the people, when they are in their 50s and 60s, they develop diabetes. So it is something of concern. And most of the people, if when they are in the stage when they are pre-diabetic, and if we provide them right kind of diet and exercise, many of them, they can be reverted back to normal sugar rather than to going towards the diabetes. It helps in the diabetes, and it decreases stress, decreases body inflammation, decrease cortisol level, improves autonomic functions, improves microcirculation, because in diabetes, a lot of people, they develop complications because of disarranged microcirculation. And this study I am talking about, this was done maybe around 3 years back, pre-COVID. And I initiated this study, and this was now it's a published study. So my concept was that when we talk about yoga, there are many challenges which I would discuss at the end. So individuals who live in the low socioeconomic status, they cannot afford to go to the different yoga studio or yoga clinic. And yoga is a something where it's not like that you do for 2 days and then it's done. No, it's for life. You have to do it in day-to-day activity. And suppose if I train somebody for yoga and I call them to AIIMS and ask them to do yoga, they would be happy doing yoga, and once they are out of that system, they'll not practice, right? So what's the use of this thing? So it's very important when you go for yoga, it should be in the setting where they do live. So I decided, let me go to the people who are from lower socioeconomic strata, living in congested area. And my thinking was that if we train them for 2 weeks or 3 weeks, and then provide some support for a few days, and let them do wherever they can do, in the house, in the nearby park, in the temple, in the school when it's not open. Suppose school is starting at 7 o'clock, and if you can make some arrangements with the school teachers and principal that so if arrangements can be made with school teachers or principals, and that space can be utilized. So all those approaches I tried, and I have enrolled individuals who were diabetic. One group was control, other was experimental group. Given yoga, 2 weeks intensive training at our center. We have a urban health center, which is in the slum locality. And then they were told to do yoga at their house, and we made it kind of, we ensured it by having twice a week by our field workers to find out what the issues, and if they forgot certain asanas and practices, then there were instructors who were telling them. And at the end, what we have found that in the experimental group, there was significant decrease in the HbA1c level, and ultimately the drugs they were taking, we were able to reduce the doses of those drugs. And this is again mechanism. So for the diabetes mellitus, how it acts, so almost the same. Then it has effect on the musculoskeletal disorder as well. It has been seen on the cancers, neoplastic disorders, different mechanism. Then coming to the then psychological. So am I audible now? Good, thank you. So there are a lot of benefits, including psychological benefit, and how there are a lot of diseases there because of stress, anxiety, especially the non-communicable diseases, and this is how the system works. And yoga acts as SP axis, also on the sympathetic nervous system, and that's how it leads to also modulate the immune response. I'll not go into details because most of the literature you will find when you do the search. I would rather prefer to discuss the questions which are of practical importance. It also improves the quality of life, anxiety, depression, cognitive function, spiritual health, and so now I'll stop here, and before going to the last slide, I will take maximum time here, and I will take questions here on this slide. So what are the issues with the yoga? Now we all know, suppose if we know that, okay, there is evidence and it is effective. तो अगला सवाल आएगा, फिर आप करते क्यों नहीं, और फिर हम क्यों नहीं बताते? What are the issues? The first issue is with the sustainability. I have done different projects, even in the MBBS students of AIMS. They were very eager to join yoga program. More than 150 students, they registered. 56 started doing yoga. And for 12 weeks, only 3 students who could complete 12-week yoga, which was twice a week yoga. That's human. Yeah. So yeah. So that's what I'm saying. The biggest issue with the yoga is sustainability. How to sustain it. And this is not like any pill where you take a pill and you are okay. You do yoga for a day and you are done. No, you have to do it for life. So sustainability is the biggest issue, and it requires a lot of motivation. You can train them. I mean, I experimented it on myself as well. Before starting all this thing, I have joined many yoga sessions, work with the SVSA and many people. 2 दिन 3 दिन तो करते थे, आने के बाद फिर सोचते थे आज नहीं करेंगे, and I'll do next day. And once there's that gap, next day never comes. So there is issue. So sustainability is the biggest issue when you have to implement a program. And when we discussed in the community, there are few issues like many people, they say, okay, I don't have time. That is very important. I mean, we don't have time. Then you have to find the way. I mean, they have to find out the ways how to get the time. If they're in the office, can we have some sessions during lunch? That I have also tried to do in one of the hospitals. Then it may be space. That is a main problem. Log ke paas, if you go to the community slums, where most of the people they do live, they don't have enough space where they can have one place where they can do stretch their limbs and do yoga. But good thing is in most of the places they'll find something nearby, maybe the temple, maybe school, maybe park, maybe some open space where they can do it. And if we can form the community volunteer group, then they motivate each other, and that helps to maintain the sustainability. So if you are doing if you are planning to go for the yoga and want to popularize it in the community, make a volunteer group, because as a program manager, as a doctor, you cannot be there every day. I mean, you can go there, you can teach them, but ultimately you have to hand over that thing to the community. The best way to hand over it to the community is through the volunteers, make volunteer group. This program which I started, this was around 3 years back. Last week I visited where the volunteer group, they are working good, they are still doing the yoga. So that is one thing, sustainability is issue, but how to make it. Then implementation of yoga program. Most of the people, they get confused with asanas. Kis yoga ko karna, kya karna. So you give them a structured program that, okay, this is the program which is good for this particular thing. Suppose if they are interested, suppose a person who's diabetic coming to you and they're interested in diabetes, I want to reduce, then there should be some program which is tested, which is evidence based, that, okay, you do this thing and this is the evidence. So plan a program according to their disease, and then implementation. One is giving them the right kind of program. Then the issue is Ayush is separate department. Now trying to integrate some services with the health and wellness center. So if we can, if many of you are, I learned, are from different states and program managers. So if we can find ways that we can integrate it with the health and wellness center, sub centers, because it is low cost program. बहुत पैसा नहीं चाहिए होता, बहुत बड़ी मशीन नहीं चाहिए होती है. What you need is the space, yoga mat, and a person who can teach them. Even the videos they can work, right? So that is the issue. I think next step which is important and which probably need discussion and some kind, I think, exercises through which if we can integrate it with the sub center, then it would be a great success. We know, like if we see, it is useful, it is evidence based, it is going to work. All of you work in the NCD, and as you know, NCD management is a multi-domain approach. So role of this complementary medicine is useful, whether it is Ayurveda, it is yoga. I have discovered here mainly the yoga because I work in that area. It is low cost, it is easy, but it's not that easy. Not that easy in terms convincing people, bringing them. The first day, yaad rakhna kahin, if you start, puri community aa jayegi. But after 15 days, you'll find 50%. My experience is the sustainability is around 40 to 50% with all your efforts, with all your motivation, not more than that. So that's it in short from my side. I think I have completed in 25 minutes, and now it is open for question if organizer permit me. Sure, I can, if organizer permit me, I can give me, yeah, sure. Very, very good. Yes.
Feasible है, हम उसको करना चाहते हैं अपने स्टेट में भी, but वो कहाँ से मिले?
Very good question, very good question. And
second, one more question कि sustainability जो आपने बोला, तो कितनी देर daily yoga practice करना चाहिए या weekly जो भी?
Okay, I'll answer both the questions. See, when we talk about yoga, अभी एक problem क्या थी? When we talk about yoga, कोई कहेगा ये आसन करो, कोई बताएगा ये आसन करो, and modern medicine they ask for the evidence. Why we could not popularize it in the West? Because they ask for the evidence. मैंने ये वाले 2 आसन कर दिए, आपने 2 आसन वो कर दिए. And what science is that if we do the same experiment, the result should be the same. Repeat. I mean, they can do the repetition of the same experiment, right? If my results are different, your results, it would not, they will not be valid. So that was issue, and that's why now for last few years we are trying to develop a structured yoga program. That this is the structured yoga program. These are the set of yoga, and if you like for the drug you do, okay, if you take this drug for so many days in this dose, this is going to be the effect. The same way we developed a program. Okay, this is the module you do for so many days, and this is going to be the effect. Government of India, they are working on it. There is one module which is called Common Yoga Protocol that is available. That is for 50 minutes. Many of the asan, I think in your registration, this folder, you might have got one booklet. Yes. So this also have the 50-minute module, and this program is especially developed for diabetes with the help of S. Vyasa University and Center for Integrative Medicine and Research, AIMS. And this program was given to the community, and where we could see the changes. So your question is about from where you get this program. Yes, you can get from the Morarji Desai Yoga Institute. From Ayush, Common Yoga Protocol is available. That is for 50 minutes. Yes, Morarji Desai is the Apex Institute for Yoga, which is established by Government of India, and Common Yoga Protocol, which is being developed by India, that is available on the website. Many of the asanas, they are here for 50 minutes. The asanas which we have given here, they have been evaluated by the 20%, and they are for diabetes. Same way, there are different modules which are available for the stress. For other diseases, they are in the development. So stress module is already available with the this Ayush Ministry, has been developed by Morarji Desai Institute for Yoga. That is government institute and Apex Institute for Yoga in the country. So I hope I answered your question well. Okay, so if organizer permit, I'll take 5 minutes. Dr. Bari, can I take 5 minutes for stretching exercise? Okay, thank you organizers for giving me this. So what I'll do is, those who want to practice, I can guide you to practice, or if you want to go out, that's up to you. Okay, आप बैठे रहिए, बैठ के भी हो जाता है. So that's what my message is. And मैं बता रहा हूँ कि जब अभी कोविड का टाइम था, तो I could get time to do yoga. And other than COVID में हमारी कोई छुट्टी नहीं थी. We were working every day. In fact, we were working more because of our involvement with many, programs and things. So one of my yoga instructor, he said कि उसको मैं कई बार बुलाता था कि अच्छा मैं करूंगा योगा, फिर वो कहता था आप ही नहीं करते हो, बाकी लोग क्या करेंगे. देन उसने फिर मुझे चेयर पे बैठा के योगा किया, एंड यू वोंट बिलीव, हम लोग कंप्यूटर पे काम करते हैं, मुझे काफी पेन लगता था बैक में. आई हैव कंसल्टेड एवरीवन इन द एम्स, MRI भी कराया, सब कुछ कराया, नहीं गया. आई डिड योगा, कुछ सूक्ष्म जो इसमें लिखे हुए मैनी ऑफ देम, चेयर पर बैठ के आई हैव नो पेन नाउ, राइट. So the first thing is, when you do yoga is, or wherever you are in office, go into very calm and peaceful state. So the first thing is, close your eye, take deep breath, कोई भी जो विचार मन में आ रहा है डिस्टर्ब नहीं कीजिए, आ रहा है आने दीजिए, डोंट स्ट्रगल विद दैट, टेक डीप ब्रेथ, prepare yourself for few yoga exercises. Take deep breath, open your eye, because then I will tell you how to do it. Otherwise, the best way is to keep close. Eye should be closed because it helps in making concentration. It will take some time. After few days, you will feel comfortable with this thing. So what you can do is, अभी सारे लोग कंप्यूटर पे बैठे देख रहे हैं, तो I'll tell 2 or 3 exercises. One is for neck. What you do, अपनी बॉडी को बिल्कुल रिलैक्स छोड़ दो, एकदम ढीला छोड़ दो, बिल्कुल ढीला छोड़ दो, जितना छोड़ सकते हो, बैठे रहो और गर्दन को नीचे लेके जाने के लिए लाइक दिस. टच योर चिन विद योर चेस्ट as much as you can and leave your body relaxed. Breathe normally. गर्दन को पीछे लाइए, बैक में जितना ले जा सकते हैं कंफर्टेबली. डोंट ओवर स्ट्रेच, डोंट ओवर स्ट्रेच. Repeat it one more time. पीछे ले जाइए गर्दन को. होल्ड कीजिए, जितने सेकंड होल्ड कर सकते हैं, एटलीस्ट फॉर 10 सेकंड्स. सामने लेके आइए गर्दन को. नाउ टर्न टू योर राइट लाइक दिस, जितना ले जा सकते हैं. Again to normal position. Now slowly towards your left. Don't overstretch. जितना आप कर पा रहे हो उतना ही कीजिए. Bring neck to normal position. Repeat it once more to your right and then to your left. ओके. अब इसके बाद जब आप घर पे जाते हैं, यू कैन प्रैक्टिस नेक रोटेशन. एटलीस्ट स्टार्ट विद द 3 times clockwise like this. Anti-clockwise. This will help you. This you can do while in your office. जिन लोगों को कंप्यूटर पे जब काम करते हैं ना, काफी पेन आ जाता है. This will help you. And what you can do is, ये जो आगे के लेके जाना गर्दन को पीछे दाएं बाएं, you can do 5 to 10 times depending. I mean, start with the 2 or 3, then as much as you can do. अभी नहीं आया होगा जिन लोग नहीं करते हैं, बाद में आपकी बॉडी एकदम रिलैक्स होनी स्टार्ट हो जाएगी। जस्ट अभी तो लगता है कि हमने एफर्ट किया हुआ, देन बॉडी ऐसे रिलैक्स होगा जैसे कोई चीज को ढाके ऐसे कर रहा है। And that, but it would take time. It will not come in one day. There are many exercises which are given there. The सूक्ष्म व्यायाम करके लिखा हुआ, हाथ का दिया हुआ है, ये सारे दिए हुए हैं. That you can do. I'll not take much time because there are many other lectures. So thank you very much. And thank you.
Thank you, sir. We'll be moving to the next session, that is by Dr. Atul Ambekar. Sir is professor at National Drug Dependence Treatment Center and Department of Psychiatry at AIIMS, New Delhi. Over to you, sir.
Good afternoon. Namaskar. Thank you very much for giving me this opportunity. So do you want me to share my screen or are you planning to project it yourself?
Your screen, sir.
Okay, fine. So today, basically, I have been given an opportunity to discuss brief interventions for alcohol and tobacco use, which are NCD risk factors. So essentially, just after a very healthy session on yoga, we are now going to discuss some unhealthy things in the form of use of alcohol and tobacco by people, but how we can help them reduce, control, or stop this use using something called as brief intervention.
Sir, you are not audible.
Literally thousands of years. Hello, am I audible?
Yes, sir. Yes, you are audible.
Yeah, thank you. So basically, since the time human civilization started, people started brewing and consuming alcoholic beverages. So use of alcohol and tobacco has been really a part and parcel of human civilization since ancient times. However, in the modern times, it has assumed really epidemic proportions. And that's why both alcohol and tobacco use are not only just risk factors for other NCDs, but alcohol and tobacco use disorders themselves are NCDs. They are addictions. So this is a kind of double burden of these diseases. They can cause other diseases, and they themselves can lead to development of use disorders or addiction, which are NCDs in their own right. As this table shows, and I'm sure all of us are familiar with this, both alcohol and tobacco consumption are among the top 10 risk factors for Delhi's, and this has been a consistent findings. The rank may go up or down, but this has always remained among the top 10 risk factors, and by all accounts, it's increasing in India. For instance, the 2019 survey, which we conducted for the Ministry of Social Justice and Empowerment, crore people are users of alcohol in India, which are current users. And very importantly, about 1/3 of them are problem users. Problem users means they are suffering from harmful use or dependence. So compared to the global average, fewer people consume alcohol in India, but proportionately, a larger proportion of Indians, they are affected by alcohol use disorders. And why this is the case? This is because what I call as the great Indian pattern of drinking. In India, when people drink, they drink to get drunk. So that's why heavy episodic drinking in excessive amounts on the occasions that you are drinking, or preference for high alcohol concentration beverages, such as spirits or country liquor, that's much higher in India, which is the reason why we get much more morbidity and much more burden of alcohol consumption in India, even though comparatively a smaller proportion of population that's consuming alcohol in India. So that's something we must remember. As far as tobacco use is concerned, there is some data to show that it is now being controlled, but still a substantial population of Indians, they use tobacco, and larger proportion of them actually consume smokeless tobacco. In fact, various rounds of National Family Health Survey have been demonstrating the slight change in the prevalence of both alcohol and tobacco consumption, though there are methodological issues in the way the question about alcohol and tobacco consumption is asked in the NFHS, and hence I have my own doubts about this of data. The question is any form of psychoactive substance use, be it alcohol, tobacco, or other drugs, is it abnormal, or when does it become actually a disorder? I was referring to alcohol or tobacco use disorders earlier. So basically, from the psychiatry, from the addiction behavioral sciences perspective, if the person is consuming a substance with a proverbial green zone of use, however, if the use further increases in a pattern which is causing harm, that's when the person is said to be affected by harmful use of that substance. This
Hello,
can further increase.
Hello, sir. The slides are not changing in the room screens. So
Okay.
I'll share the screen slides.
Uh,
Just give me one.
Fine. So I will stop sharing my screen now.
Yes, sir. Please do, sir.
You can take it to that screen, which was last visible. Yeah. Right. Right. We can stop here, please. Yes. So basically, and then the last phase of substance use pattern is development of dependence, when it's difficult for the person to stay without using that substance. This can very well and does occur with both alcohol and tobacco as well as other psychoactive substances. Next, please. And both of these are actually considered as substance use disorders. Next, please. Please keep clicking. There are lots of animation in this slide. So if we see the society in general, in the general population, a large majority of people are actually abstainers who do not use substances, followed by a smaller proportion of occasional users, followed by harmful users, and finally a tip of this pyramid is formed of small proportion of people affected by dependence. However, most of the public health burden is actually caused by this tip of the people suffering by drug use disorder, suffering from substance use disorders, either dependence or harmful hazardous users. So next, please. Yes, next, please. The question is, how do we deal with it? For dealing with this, basically, in terms of the classical public health teaching, we have the primary prevention strategies in the form of awareness or coping skills for either those who have not started or those who are occasional users. For people affected by the use disorders, people who are at the harmful or hazardous risk category, for them or people with dependence, we need secondary prevention strategies such as treatment and rehabilitation. Next, please. And the package, which is basically we employ for alcohol and tobacco use disorders as a risk reduction strategy, goes by the name of SBIRT: screening, brief intervention, referral, and treatment. Proceed, please. So what is screening? Let's proceed, please. So there are basically some screening tools, which means a set of questionnaires, which can be asked to people who are suspected of having alcohol or tobacco use problems to determine what kind of help they need. For instance, CAGE is a very common one, followed by MAST, DAST, Audit, Assist, and many more. Next, please. So CAGE, when we talk about CAGE, is simply a set of 4 questions. Answer to any one of this in yes indicates alcohol use problems. Have you ever felt you should cut down drinking? Are you annoyed by when people talk about your drinking? Do you feel guilty? In the early morning, do you need to drink? So if any one question is answered as yes, That means the person is highly likely to have alcohol use problems. But the more useful for us are the screening tools developed by WHO, which are specifically linked to intervention, particularly audit, which is only for alcohol, and assist, which is for all substances. Next, please. So assist basically stands for alcohol, smoking, and substance involvement screening test. So it takes care of all the possible psychoactive substances. A set of questions are asked to the person. The responses are recorded, and for each response there is a score. Next, please. And then on the basis of the risk of the score of that person, the person can be assigned to a particular risk category: low, moderate, or high risk. The beauty of this instrument is it takes just about 10 to 15 minutes. If the person is not using too many substances, just about 10 to 15 minutes. If the person is using more substances, at the most, let's say about 20 minutes. So you administer this questionnaire, and there and then itself, you can decide what category this person fits in and what type of intervention this person requires. So if someone is just at the scores are at the low risk level, they just require support and some kind of advice about promoting healthy behavior. If they are in the moderate risk, that's when they require what is known as brief interventions. And finally, if they are at higher risk, they require referral. But for this referral also, we can use brief intervention, and which can increase their motivation, and thereby they can receive this referral. So brief intervention is primarily the strategy which is useful for the moderate risk category. What do we mean by this? Simply a brief counseling which aims at changing specific behavior. In this case, use of smoking, tobacco, or alcohol. Very short duration counseling. One session may be enough. In some cases, 3 or 4 sessions, let's say about weekly intervals, they may be required. A very important part of brief interventions is you do not really require a doctor to do this. Anyone, doctors, psychologists, nurses, social workers, general health workers, even peers can be used to deliver brief interventions. And we have had extensive experience of training non-professional cadre for the purpose of delivery of brief intervention with very encouraging outcomes. Next, please. So what does this counseling actually involve? The mode of talking actually can be summarized with this acronym of FRAMES. Now, this is not really a training program in the clinical sense, so we will not go into details of this. I will just very quickly familiarize you with what does FRAMENS stand for. Let's proceed, please. Yeah, keep going, keep going. Right, next, please. So basically, the first F stands for feedback. Feedback here means next. Feedback here means a personalized feedback. So you just ask the client, the person, about the problems they have faced because of their substance use. Later, you just make a list of it and summarize it for them so that they realize that what all problems they have faced because of their substance use. Remember, in feedback, you are not supposed to talk about the potential harms. That Mr. Kabir, if you keep smoking, you will die of lung cancer. No. Mr. Kabir, you have told me that since you have started smoking, your stamina has gone down. That's what feedback entails. Next, please. The R stands for responsibility. And here, the idea is to let the person know it's you who have chosen to use the substance. It's you who will have to make the choice of reducing or quitting this substance. So in the decision-making process, it supports the idea that no one is forcing you or pressurizing you. Next, please. A for advice actually is just simply about straightforward advice on modifying their substance use. Right? It appears like it's a good idea that you should change your behavior. That kind of thing is advice. Next, please. Stands for menu of options. Now, many people, when we talk to them about reducing their alcohol and all the roads are being closed for them, we can tell them actually there are a variety of doors which can be opened for you. You can so that which again in a way supports patients' autonomy and decision making, and hence likely to be much more acceptable to the patients. Next, please. The next E stands for empathy, which means talking to the person in a respectful, in a non-judgmental manner, trying to understand their perspective as well. What happens most of the time is health workers, whichever level they are on, they tend to take a very moralistic tone on when they find someone with alcohol or tobacco use. For instance, smokers are just told in one line, "Oh, very bad for you. We are doing a harmful thing. Just stop it." Right? And that's where the health worker thinks that their duty has concluded. If it were so easy for them, they would have done it before you telling them. So idea is to engage them in an empathetic, non-judgmental conversation by which they can be supported to change their own behaviors. Next, please. Next is the final idea is just to support their self-efficacy and giving them a message that this can be done and you can do it. So very often the idea of our patients is मेरे से नहीं होगा, मेरे से नहीं छूटेगा. Idea is to just give them this confidence, this can be done and you can do it. Next, please. So basically all this discussion on brief intervention, this takes place with a particular kind of interview or interactional style, for which even as I was saying, non-health professionals can also be trained. So how to develop an engaging relationship, being respectful, being attentive and empathetic to the patients, being totally non-judgmental, not looking at patients' behavior with a moralistic lens, that what you are doing is dirty. I am cleaner than you if since I am not a smoker or I am not an alcohol user. If that kind of attitude is avoided, it's better. It becomes easier to develop rapport with the patients and then help them change their own behavior. Next, please. So to conclude, we must now start accepting that alcohol and tobacco use will continue to be for the at least next foreseeable future as a part of life, part of society. Some individuals will continue to use them despite best efforts from all possible stakeholders, and hence we need to move away from this vice versus virtue dichotomy, whereby using these substances is a vice, not using them is a virtue, and hence people using these substances are somehow dirtier people who do not deserve the kind of empathy others deserve. And also it's very important that as an aspirational goal, calling our country or our state or our city as tobacco free zone or alcohol free society is fine, but practically it's never going to be possible. So let's avoid this jingoism and let's see how best we can work around having a balance. That's why we need to promote all possible preventive, therapeutic, as well as harm reduction approaches. Harm reduction approach basically would mean that while continuing to use a substance, can the person use it in a manner which reduces or minimizes their risk or their harms? For all this, it will be very important to build capacities of health systems, specifically in adopting screening, brief intervention, and referral, because this is really low cost, low intensive kind of strategies. At all levels of healthcare, these can be employed, and training on employing screening or brief intervention. Any decent psychiatry department of any medical college will be able to take up this task and provide this training to the healthcare cadre. So this is going to be very effective public health strategy to address NCDs. That's where I would conclude. This is our the picture of our treatment center at Ghaziabad. Thank you very much, ladies and gentlemen, and cheers. If there are any questions, I'll be very happy to take them.
Thank you, sir. Are there any questions? There are no questions from you.
Hello, sir.
Hello.
The one who is alcoholically addict since like 10 to 15 years, continuously taking the alcohol. So what will be the treatment for them? So they are already totally depend on it. If they leave it, their daily routine, it's not possible to run normally.
Yeah, absolutely, absolutely. As I was saying, both alcohol and tobacco are dependence-producing substance, and if people have developed alcohol dependence specifically, then quitting alcohol without medical supervision or treatment can be dangerous or fatal for them. Sudden lockdown last 2 years back actually resulted in a withdrawal-related death of few people. So alcohol, if someone is physically dependent, they must receive adequate medical treatment for this. Fortunately, treatment of alcohol dependence is fairly simple, fairly easy in trained hands. So any general physician can also be trained to provide treatment of alcohol dependence, which involves treatment of acute alcohol withdrawals. It simply requires use of oral benzodiazepines and multivitamins, particularly of B complex group. So using this in supervised manner, in a systematic manner, engaging the patients in a comfortable non-judgmental manner, takes care of their acute withdrawal symptoms. The bigger challenge is to avoid their relapse. And then there are psychological as well as pharmacological. In fact, there is a special training module which we take for health professionals on management of alcohol dependence. Thank you.
Thank you, sir. Sir, is your the tools which you have shown, is it standard one which is available on free port?
Yes, of course. It is developed by WHO. It's standard, and I had requested organizers also to share with you the as a handout or as a link the manual which is available on WHO website.
That will be very helpful, sir. Thank you very much. Yeah.
Well,
Thank you, sir.
thank you.
There is one more question.
Yes, please.
Thank you for that nice presentation. I have got two questions. As you have said that alcohol use is one of the disease, non-communicable disease. So when you will call this as a disease, and what are the known risk factors for that?
Right. So I suppose at the point where our presentation got stuck and it had to be switched, that's where we were discussing this. So when a person is consuming alcohol in a pattern which is not causing any harms, any problems to the individual, that will be simply called as alcohol use. But when a person is consuming alcohol in a pattern which is causing some physical or mental health harms, or to the harms to health of others because of that person's alcohol use, that will be regarded as harmful alcohol use. Dependence is the next stage where the person is using alcohol in a pattern which indicates a loss of control, which means almost daily consumption in very high amounts, experiencing withdrawals on not taking alcohol, experiencing severe craving on not taking alcohol. These are the criteria on which we make a diagnosis, indicate harmful use or dependence, and to make a judgment, because not everyone is a doctor, so or a psychiatrist. So to be able to determine whether this person actually needs help for his alcohol or tobacco problem or not, the screening tools like WHO Assist, they exist. So on the basis of applying those questionnaires, we can determine, looking at the scores, whether this person is likely to be suffering from alcohol use disorders and whether this person requires brief intervention, simple advice, or referral to a specialist center.
Thank you, sir. Now we can move to the next session.
Thank you.
Next session is by Dr. Suresh Kumar. Sir is director at WHO Collaborating Center for Community Participation in Palliative Care and Long-Term Care, and technical advisor at Institute of Palliative Medicine, Calicut, Kerala. Over to you, sir.
Thank you. Am I audible?
Yes, sir, you are audible.
Okay. Good afternoon, everybody. Last session of the day and already delayed. So I'll be really brief and crisp and practical. So I will not take too much time. I've been asked to talk about implementation, planning and implementation of palliative care. So I'll focus on basic principles from a very practical point of view. Can I share my slides? Yeah, I think so. Yes. Is this visible? Slide?
Yes, sir, it's visible.
Okay, right. So I don't have many slides. It's something like less than 15 slides. So this is what we are trying to do. I'm looking at it from a planner's point of view, and I'm looking at it from the public health point of view. How do you plan and how do you implement? Before that, yeah, you all know what palliative care is. I'm not going into detailed definitions or anything, but basically this is exploration of what can be done to help people in the final phase of their life. All of us, any patient, any individual. And the final phase is very difficult to define, particularly when the old age merges with death and dying and all these things. But generally last few years and sometimes last few months. And it has basically, when you look at it practically, three components. One is prevention and mitigation of suffering. I'm using the word suffering. Suffering related to incurable illness, life-threatening illness, and death and dying. It can be old age, it can be multiple diseases, it can be a single disease like cancer. How do you prevent suffering when the disease cannot be cured? That's the one question. Second question is, how do you ensure that the person die with dignity? And the third one is, how do you support the family with bereavement support, family and people close to the person? So this is the concept. And this is again, we are looking at suffering. We are looking at health-related suffering. The suffering that happens due to a particular disease or particular illness, which is incurable, or but multiple diseases and disorders at the end of life, old age. So how do you address? So when you look at it, for convenience, this is conventional to divide into 4 major domains. One is the physical issues, like person may be having pain, breathlessness, a strictly medical and nursing area. Then you have social problems, many of them. Financial issues are the straining relationship. Many of them feel isolated, social isolation. And then quite a few emotional problems. People generally get panic when they feel that, okay, there is incurable illness, or when they are likely to die in a few months' time, people get panic. Sadness will be the anger towards the system, anger towards God, anger towards family. Worries will be the anxieties, will be the feeling helplessness. That's also there. And spiritual problem, whether you're religious or not, you start thinking about the meaning of life. What have you achieved by living so far? Was there any meaning in what you have done so far? So this is also, and some people it appears as religious concerns, and for other people it appears as existential concerns. So these are the issues. Like when you say that you are addressing suffering, unless you address all these domains, it will not be effective. So obviously, it's beyond medical because when you talk to a doctor or a hospital or a medical system, they know how to address a physical problem. They know how to address pain, suffering, pain, breathlessness, vomiting, etc. To some extent, some of them may be able to address the emotional problems also. To some, but then what about the social issue? What about the spiritual issues? So when you say that this is addressing suffering, you have to address all this. This is one major difference between palliative care and other areas of care. And it's a big challenge. Challenge in many ways. Numbers are quite big. Larger number, and their patients are spread out in the community. It's not a single diagnosis. Somebody may be having advanced cancer, somebody may be having advanced renal disease, somebody may be having old age with late stage diabetes and cardiovascular diseases, multiple problems. And then mobility will be limited. These people cannot access, even if you have a really good service at some place, traveling to the service place and getting access is difficult. Most of them have limited mobility. And then also, like for the rest of their life, they need support. It's not just one OP attendance and going back. So how do you support them? And then there will be crisis in between, worsening of the symptoms, some other emotional crisis, social crisis. That's the so the intervention. When you look at the intervention, as I mentioned earlier, it's not just medical intervention. You need to have diverse interventions. How do you address the social problems? How do you address the spiritual issues? How do you address emotional problems? How do you address physical problems? So scope of intervention is diverse and it's a little bit complex. And then we are all familiar with the medical domain. We know how to how to manage a pain. We know how to manage a plethysmography. If we do not know, we can always refer and get some. We know how to use a medication. But most of the doctors are not familiar with the other domains. For example, how do you address spiritual issues? How do you address social issues? So we cannot work alone. That's another issue. And the challenge is to how do you find a way to assure continuous and meaningful care to this sort of issue, these complex issues. How do you address? How do you take a lead, and how do you maintain the system? And when you look at the patient, this is what's happening. You can see the patient in the center. Patient is generally, any patient in our particular, in our situation, supported by three systems. One is the formal, the formal health or social welfare system, the primary health center, the three-level hospital, government hospitals, private hospitals, whatever, that's there. It offers some support. And then most of the care, most of the attention is by the informal personal support system, family, immediate carers, immediate neighbors, people who are close to the patient. They are the people who spend maximum time with the patient. And then there is also an extended system of extended family, neighbors, any other non-governmental organizations, people in the community. So any patient gets the support from the three systems. In some places, it's mainly informal family support, not much of healthcare support because some of the rural places that is happening. And some places there will be more of community support. And so this is varying extent, but the elements of all the three are there. So this is the strength, and this is the sort of possibility, opportunity that for the patient to be comfortable, all the systems need to be ideal. All the systems, we need to get maximum possible support from all the three systems. So that is the plan also. When you build a palliative care service, the idea is to make that you ensure that the patient gets maximum possible support and continuous support from the combination of these three systems. Systems. And also we always talk about, in palliative, we talk about the 95% rule. 95% rule is that when you look at the patient, any patient in palliative care, even somebody being looked after by a well-established center, palliative center, 95% of the time, the patient, in the last few years or few months, 95% of the time, patient is with family, with the community, and not in the hospital. Most care for the illness is delivered in biomedical institutions or by professional practitioners, but by the family, friends, and neighbors. So that's the strength, and that's the weakness, and that's the opportunity, because the patient is with the family, patient is within the community most of the time. Only 5% of the time, even if you have a center, they'll be spending only 5% of the time with the professionals or with the institution. This is what we call. So most of the attention need to be in the community. And the model of care, the ideal situation would be looking at all these three. Ideal situation would be all the three are good. All the three systems of care are good. That is, the informal carers around the patient, whether from the family or in the community, they are aware of the problem. They know how to do it. They're competent and they're supportive. And that's one major factor. And then extensive basic palliative care network in the community, because people can support from outside the NGOs or some other group. And the primary healthcare system within the community, health and wellness centers in the community, they offer support. And then there should be an institutional backup for training and referral. So different models are available, but unfortunately, most places in India, they start only with the institutional backup. They develop a palliative care department or establish a center in the hospital, forgetting about the reach, forgetting about the community, forgetting about the basic primary healthcare system. And only patients who reach the institution get some support. And also only 5% of the time, 95% of the time, patient is left unsupported. So this is the what we call the public health model approved by the WHO. This has been this is getting more popular after the World Health Assembly Resolution 2014. WHO has officially more or less now come to the stand that this is what is needed. You need specialist center, you need palliative specialists, people who have been really qualified, and centers there at the top. Only for a few patients, like most of the patients can be looked after by the primary healthcare system if they are empowered to do it. And then most of the care again happens in the community. And then our role will be to empower the community, empower the informal care. Make sure that the informal carers know what to do. Make sure that the informal carers don't just feel helpless. Make sure that the informal carers network with each other. Make sure that there is a connection between the informal carers and the primary healthcare system. Make sure that the primary healthcare system knows what to do. Most of the symptoms, most of the medical issues there are simple. They're not complicated issues, but the whole system is complicated. When you look at the whole problem, the problem of suffering, this is complex, but the medical issues are not that complicated. So primary healthcare system, they should know, the health and wellness centers, the primary health care, they should know what to do. And they should be supported and trained by the specialists. This is the basic approach that we have been advising. And the key, when you set up a palliative care service, we tell people to remember 4 things mainly. Basically, 4 things. One, death and dying are not just medical issues, or the illness experience of chronic illness, end of life. It's not a medical issue alone. This is a social issue with a medical component. There's a definite medical component, but you cannot control the problems with an injection or a tablet or a medical visit or a nurse visit. So this is something that we need to remember. These things are beyond our domain. And again, the 95% rule that I mentioned, that 95% of care happens outside the institution, not within the institution. And then what we call the social epidemiology of dying, and caregiving and bereavement. Illness experience is again more than physical symptom. What does the patient, when you look at the suffering, when you want the suffering that you want to prevent and you want to mitigate, what does the patient undergo? The patient undergoes physical symptoms, definitely okay, but the patient also undergoes panic, helplessness, depression, sadness, anger, social isolation. So we need to cover that also. So this is social epidemiology of dying is not medical. And then it need to be holistic. You cannot, unlike most of the institutions which offer medical care and say that this is palliative care is more holistic. Palliative care need to have all these components addressed, and there should be a system to address these components. So capacity building, one is the strengthening the basic informal caring system. Improve the skills and knowledge. This should be part of, because that they are the skills of knowledge of the family members, the carers, neighbors, people who are interested in supporting the volunteers, because they are the people around the patient. They should know how to talk to the patient. They should know how to listen to the patient. They should know how to feed. They should know how to transport the patient. They should know how to prevent a bed sore. So these are the basic issues. So, and teach them, improve their skills and knowledge, and network, facilitate. There will be groups of people who know this and groups of people who may not know this. Facilitate networking. This is what some of us have been doing in particularly in Kerala. Train a lot of laypersons, not on medical issues. A lot of laypersons in areas where their intervention will be helpful and the intervention will be support to the medical team. So train them, network, and then capacity building at the primary healthcare level. The primary doctor in the primary healthcare level or the nurse in the primary healthcare level should know how to diagnose symptoms and how to treat symptoms. Basically, pain, breathlessness. There are some 11, 12 basic symptoms which they should know how to treat. So these are protocols are available. It's not tough, but people should know. And some of the medicines available for these symptoms should be available. And then the specialist system to supervise, to refer, for the policy decisions, and for taking up references. And this is the referral centers in hospitals, like all the institute has a palliative care unit, but it will not be helpful, will not be serving or making a useful role unless it's supported by the other two, unless it's supported by a well-aware, the empowered community and the empowered primary healthcare system. So it means this is what we call public health approach in palliative care. This is what the standard norm now in many places, and most of the institutions are now trying to move into this direction, but it's not easy. And this will mean reframing palliative care as a social experience rather than just as a medical issue. Secondly, this is an approach which allows individuals, people who are connected with the patient, the carers, family members, neighbors, classmates, friends, to take an active role in caring rather than just feeling helpless. Active role in caring in partnership with the professional teams. So this is they need to know what to do. They need to know how to do. And the organizational challenges is not easy because this is not very much in line with the existing healthcare system. The existing healthcare system, though we have there's a primary healthcare are the first primary, secondary, tertiary structures are there, and more focus on the tertiary care and more focus on specialist hospitals. Without much concern about the community involvement, community participation, what can the primary healthcare system do, what can the health and wellness centers do. So this is the one challenge is how do we develop public health principles alongside our institutional priorities? How do we make sure that, okay, we develop a palliative care department, we develop a palliative care unit in a tertiary care institution or a secondary care institution, but how do we also make sure that this is in line with the public health approach? How do we develop partnership with other sectors, for example, ordinary people, laymen, other institutions, workplaces, schools, local government, because this is everybody's business. All of us will have to die one day, and only 10% of us will die suddenly. 10% of us will die suddenly without being bedridden. It can be an accident, it can be homicide. I'm talking about you and me and people around us. 90% will be bedridden for a period. So people around us should know how to look after us when we are bedridden. So this is so everybody should know. And again, when though we know that everybody will die one day, generally there is a tendency of ghettoing. If you look at the dying man and you feel that, okay, poor chap is dying, without realizing that dying is also part of life. So usually what happens is dying is kept as a separate one. Dying is the other side of the wall, and you are all on this side of the wall unless you move there, and when you move there, you move alone. So we need to see dying as part of life, and we need to, that sort of life and living issues, caregiving and grief need to be mainstreamed and avoid ghettoing. And basically this will again mean people being aware, people being competent, people being helpful. This is broadly, this will mean creation of compassionate communities. Like communities need to be more compassionate, and also within the institution also this sort of attitude. So this is what I have to say. This is my email address. It was really brief, and it was actually because of limitations in time, I could not go into details. But I'll be very happy to take respond to any of your messages or questions. And if you have time, I'll be happy to take a few questions here, sir.
Good evening, sir. I'm Jagannath Reddy from Telangana.
Yeah, please.
Actually, we have taken Kerala as a model for our palliative care services. And Dr. Gayatri Pallat, who's a Keralite.
She was my colleague earlier. Yeah.
Yes, sir. She's our nodal officer. And with her support, we were able to start 33 palliative care centers.
I know.
My only issue, sir, 1%, as per the surveys and statistics, it says that 1% of the population needs palliative care. With 33 centers, with the 6 to 10 beds, I think hardly I was able to put up about 250, 260 beds, and home care, I'm able to cover 30 kilometers from the center, not beyond that. So when I try to apply for morphine license for my primary health center medical officers, the drug control department says that pain relief and palliative care training of 28 days is mandatory. It is becoming difficult, sir. Is there any way out?
Yeah, because there is again this mandate, like the NDPS, Narcotic Drugs and Psychotropic Substance Act, only says that the person holding license should have adequate training. It's up to the drug controller to define what is adequate training. For example, in Manipur, where I have initiated a program and I'm working with them, a lot of programs on health and wellness center level. They have approved 3 days training as the basic training. In Kerala, the drug controller has approved 7 days training as the basic training. So I think you need to talk to the drug controller, because basically what do you need to know? You don't have to master whole of palliative care before you get the license. You should know how to handle morphine. You should know how to handle opioids. You should know what is the protocol, how to administer, what are the side effects, how do you control. How do you keep that? So this can be actually sort of, many of us have been arguing that this can be learned in a day. Why do we like make it too complicated by making it 28 days and all? So I think you need to go back to the drug controller and put pressure on it, because Yeah, this is not difficult. This is not complicated. For example, an oncologist who uses much more potentially harmful, much more with more complicated drugs, and then when he wants to apply for a market license, he is asked to undergo this prolonged training. In fact, he uses much more harmful drugs with caution and with competence. So this is like learning how to control pain, learning how to use analgesics to control pain, and what are the side effects and how do you store them. It takes only a day. So I think there are states which actually agree on a shorter terms, shorter courses. One thing I think for the Pallikar unit or the Gayatri's unit, the first thing to do is to prepare a module, prepare a training module. This is what we have done here. Prepare a course basically for the to learn about pain relief. How do you use opioids in palliative care? And prepare it, and then it can be 1 to 1.5 days, including hands-on. It can be less than 3 days, and then approach the drug control and get it approved. Because unless you have a structured course, one reason why this 28 days came was maybe because the structured course is for 28 days or 1 month.
Thank you, sir. So any more questions? Well, online participants, we would like you to switch on the video. We have not met any of you, so it will be great to see you on the screen before we end the session.
Okay. Something similar to a group photographer.
That's what that is the plan, sir. So I think most of them
Yeah,
I've already closed the session. Oh no, there are a few, I think. So as of now, sir, no more questions. Thank you so much for guiding us on this important topic and a long way to go for the same. So
yeah,
okay,
people are in the camps.
So if few more of our online participants can start the video, please. So we would also need your active participation. It has already been the 3rd day and we have 1.5 more days to go. So please, you can also ask questions and be more interactive. Hopefully, it will not be so hectic tomorrow and day after. So we would like to end the session for today. We won't have any group discussion. We are who are physically present, the participants will be going for the nature's walk, and you can have a break too. So thank you all for joining the session. Thank you so much, sir, for giving us the wonderful session. Thank you.
Thank you, madam.
Thank you.
Thank you.